झापामै हो?
म अहिले धरानमा सर, बीपीकेएसमा।
ए हो, को न्युजमा आइरहेको थियो बीएमसी हस्पिटल मेडिकल कलेजको आजको न्युजमा
डाउनलोड
के आइरहेछ सर?
त्यो मेडिकल कलेज बीएमसी कराउने पास भयो काठमाडौँ युनिभर्सिटीले भनेर आजको पेपरमा बडा आइरहेको छ। त्यो मान्छे धेरै इन्फ्लुएन्सियल मान्छे जस्तो छ, बढी नै हाम्रो प्रसाईजी दुर्गा चिने होला नि। तर मेडिकल कलेज आउँछ त्यहाँ, अब के हो कुनै
अन्जना म्याम
अरू घरमा सधैँ के अरे पुरुषोत्तम
सन्चै छ सर, सन्चै छ सर।
ए गुड। अच्छा विकेन्डमा आइराख्यो एउटा यहाँ धरानमा होइन?
हो सर।
ए
डाउनलोड गरेर
Sanjana ma'am, ma'am, can you hear me?
Send to desktop. Okay.
Sanjana ma'am, can you hear me?
Ma'am,
to go for live.
आजको प्रेजेन्टेसनको क्रोनोलोजी चाहिँ के थियो?
प्रेजेन्टेसनको क्रोनोलोजी सबभन्दा पहिला एउटा वशिष्ठको माइक्रोबायोलोजी, त्यसपछि इएनटी, आई,
वर्चुअल ब्याकग्राउन्ड,
त्यसपछि डाक्टर साहबको ब्रेन, अनि लास्टमा आएर यो इन्टेन्सिभ केयर युनिट भएको क्रिटिकल केयर म्यानेजमेन्ट, अनि डिस्कसन क्वेसन एन्सर। क्वेसन एन्सर हामी लास्टमा लियौँ। पहिला प्रेजेन्टेसन स्मुथली सबैको जाओस् अनि सबैले पार्टिसिपेट गर्नुहोस्।
हुन्छ, म स्लाइड मिलाउँदैछु, एकैछिन स्लाइड मिलाउँछु है।
टाइम पनि छ।
अनम्युट हुनुहुन्छ नि त, म त अनम्युट नै छु होइन।
रोहित
हजुर सर भन्नुहोस्।
त्यो के अब प्यानलमा कहाँ हामीले देखेको त्यो प्यानलिस्टहरूमा त्यो मोडरेटरले हो कि युजुअली कन्भेनर हो, डाइरेक्टली इन्डिभिजुअल प्यानलिस्टलाई एड्रेस गरेर त्यो सोच्ने गरे पनि हुन्छ कहिले कहिले कुनै आई डोन्ट नो। यहाँ कसरी हाउ आर यु गोइङ टु के इन्भल्भ दि प्यानलिस्ट?
यसमा मोडरेटरले क्वेसनहरु जुममा आएको क्वेसन युट्युब
एनीबडी क्यान एन्सर,
अनि या हु इज मोर रिलेभेन्ट
रिलेभेन्ट
मान्छेले एन्सर गर्नु ओपिनियनहरु।
You are also your panelist, I believe, होइन?
म होइन सर, प्यानलिस्टमा हो।
सर एकछिन म एउटा भन्ने है यसमा, अनि हामी यो डिस्कसन पोर्सनमा चाहिँ हामीले सायद अब च्याट अप्सन्स फेसबुक अथवा युट्युबबाट पनि क्वेसन्स कसैलाई इन्डिभिजुअल डाक्टर साहबहरूलाई नै समथिङ होइन, कसैलाई यो डाक्टर साहबलाई यो क्वेसन भनेर उहाँहरूले सोध्नु भएको छ भनेदेखि वी क्यान कम्युनिकेट त्यो चाहिँ अडियन्सबाट चाहिँ डाक्टर साहबलाई होइन, सम डाक्टर साहबलाई चाहिँ यो क्वेसन आएको छ भनेर हामीले भन्छौँ सर।
सम्बन्धित हुनु पर्यो।
हजुर सम्बन्धित, अब सायद अब लाइक अब माइक्रोबायोलोजी सम्बन्धी अथवा एएनटी सम्बन्धी छ भनेदेखि अथवा होइन अब अडियन्सबाट चाहिँ एएनटीको डाक्टर साहबलाई भनेर आउनु भयो भनेदेखि अनि हामीले त्यही नै हजुरहरूलाई कम्युनिकेट गर्छौँ सर।
ए हुन्छ,
मैले बोलेको क्लियर सुनिन्छ सर?
गजब सुनिन्छ, हाम्रो सुनिन्छ कि सुनिन्छ कुनै
सुनिन्छ, राम्रो सुनिन्छ सर, थ्याङ्क यू। मोबाइल चाहिँ साइलेन्समा राख्नु होला।
एउटा वशिष्ठ आउनु भएको छ नि के हो?
म यहाँ मिटिङमा साइलेन्स केही थियो कि यो 1-2 घन्टा लाग्छ, के जरुरी छ र 1-2 घन्टा लाग्छ? के पुष्पासँग कुरा हुन्छ मसँगै कुरा
ए हजुर ए हवस् एक्टिभेट गर्ने डबल क्लिक गर्ने हो ए हवस् हुनुपर्छ सुज ए भनेर त सुज भर्जुअल ब्याकग्राउन्ड आउँदैन यसमा ए पर्छ ल ल ल ल ओके ओके हजुर आया 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 एड इमेज पर नोन भन्छ भर्चुअल ब्याकग्राउन्ड भयो प्लस गर्ने हो ए ब्याकग्राउन्ड म ब्याकग्राउन्डको यो गरिरहेको थिएँ
अनि ब्याकग्राउन्ड गाह्रो भयो भने छोडिदिनुहोस् आफ्नो
ठिकै
नेटवर्क
छ आउँछ डाक्टर साहब आएको हुनुपर्छ
आएको छैन सर हजुरको ब्याकग्राउन्ड आएको छैन अहिले
क्लिक गर्दैछु
Hello, Sanjana ma'am. From 2 minutes to go for live. All the participants from here 2 minutes to go for live.
एउटा जेन्टल एउटा एउटा वशिष्ठ यहाँ आउनुभयो अन्त
Hey. Hello.
हेलो
So the live show will be going within 2 minutes. So we are waiting for the participants to join. Okay. So are we all ready? All the panelists and the speakers, are we all ready?
I'm ready. Yeah.
ready.
Ready?
Yeah, we are ready. I'm ready.
Yes,
Dr.
very
Basis, sir, Dr. Basis,
Yeah.
Dr. Rizal.
All the participants, Sanjana ma'am, maybe the participant will be registered yet. The 418. I am repeating 418. The participant register now. Shall we go for live now or we wait some more time?
Let's wait for 1 minute, please.
Yeah, 1 minute. Yeah, you will
Okay,
wait
sir.
for 1 minute.
So sir, I will, ma'am, I'm waiting for your approval. When you give me the thumbs up,
Okay.
I will give the countdown. Then we go for live.
You can see me, right, Krishnaji?
Yes, ma'am, you will be able to see.
Go. कृष्णजीले तपाईँलाई भन्नुहुन्छ कि उसले के भन्छ मैले चाहिँ उसलाई इन्फर्म गर्ने त्यसपछि उसले भयो भनेर मैले कसरी थाहा अनि मैले अनि नमस्ते हुन्छ गरेँ हुन्छ केही प्रब्लम छ अहिले एकछिन हुँदा बाहिर बस्दा नि खुसी तानेर उठे खुसीबाट लाने कोही बेला आउनु सजिलो भयो नि त फर्स्टमा भएर आइरहेको छ नि पार्टिसिपेन्टहरूले के जोइन गर्नु भएको छ
डक्टर जेन्टल तपाईँको ब्याकग्राउन्ड राम्रो आइरहेको छैन एकदमै नभए ब्याकग्राउन्ड हटाइदिनु भयो हुन्छ
हटाइदिनु हजुर हुन्छ
त्यो एकदम हाफ फेस मात्र आइरहेको छ त्यो ब्याकग्राउन्ड पनि
हजुर
थ्याङ्क यू बेटर
Okay, are we all ready? Shall we start now?
Yeah, start.
Okay, I'll give a thumbs up to...
Yes.
Ma'am, we set to go for live?
Yes.
Okay, all the participants, please mute the mic from your end. And if you are viewing the webinar also the same nearby you, please mute the speaker. Otherwise, it's getting the echo sound. 3, 2, 1. We are live now.
Namaste and a very good evening to our respected chairpersons. Namaste and a very good evening to our respected chairpersons, all the panelists, speakers, delegates and participants present in this webinar, Mucormycosis, a current challenge in the medical practice. Myself, Dr. Marisa Amatya, and Orbit and Oculoplastic Surgeon from Telangana Institute of Ophthalmology, Kathmandu. On behalf of the organizing committee, it gives me an immense pleasure to cordially invite you all in this multi-specialty webinar organized by Nepal Ophthalmic Society. I thank you all for finding time in your busy schedule to be here today. Myself, with Dr. Chani Pradhan, will be anchoring the meeting. For any queries or help during the presentation, you can contact us through chat options. We emphasize to complete the presentation within the 20 minutes, and the possible discussions and any question and answers will be taken at the end of the session. As this is a virtual conference, I would like to make your kind notice that if any internet connectivity issue occurs for me or you, kindly do not panic for the same. The next speaker, according to scientific program, can start their presentation. Now, I cordially welcome you all to join the webinar and would like to start the webinar. First of all, I'd like to introduce our distinguished chairpersons, Professor Dr. Om Krishna Malla and Professor Dr. Rohit Saidu. Professor Malla is current president of the SARC Academy of Ophthalmology. He was president of Nepal Ophthalmic Society in the year of 1995 to 97 and was medical director at Nepal Eye Hospital 1995 to 2000. He was the chairman, organizing committee and scientific subcommittee, 16th Congress of Asia Pacific Academy of Ophthalmology 1997. He was the president of Rotary Club of Kathmandu District. He was a council member of Parliament in the year of 2006-14. Dr. Malla has contributed immensely in the development of retina services in the country. He is felicitated by Nepal Vitreoretinal Society in 2018 and by Nepal Ophthalmic Society in the year of 2019. He was also awarded Distinguished Service Award APAO in 1993. He has many scientific publications, both in national and international journals. He believes in service above self, the Rotary motto, and helping others. Dr. Malla is our distinguished chairperson as well as a panelist for today. A very warm welcome to you, sir. It will be an honor to hear from you and sharing your experiences with us.
Thank you.
Our next chairperson for the event is Professor Dr. Rohit Saidu. Dr. Saidu is the president for Nepal Ophthalmic Society 2020 to 2022. Dr. Saidu is a hospital director at Telangana Institute of Ophthalmology. Dr. Saidu is a founder president for Nepal Society for Oculoplastic Surgeons. Dr. Saidu is the vice president for Oculoplastic Society for South Asia, and he was the vice president for Asia Pacific Society for Ophthalmic Plastic and Reconstructive Surgery 2018 to 2020. Dr. Saidu is honored by awards like Asia Pacific Academy of Ophthalmology, APAO Distinguished Service Award in 2014 Tokyo. Dr. Saidu is one of the prominent
plastic eye surgeon in the country and participates as an invited speaker in the country and overseas conferences regularly. Professor Saidu is an international master trainer for cataract, orbit, and oculoplasty in Nepal and in Pacific Islands and Africa for a decade. He has more than 24 software publications in peer-reviewed ophthalmic journals. Dr. Saidu is our distinguished chairperson and speaker for today. A very warm welcome to you, sir. We will be delighted to hear from you. Moving to the next, Dr. Purushottam Joshi. Dr. Joshi is a vitreoretinal specialist, pediatric ophthalmologist, and strabismologist at Mechi Eye Hospital. Dr. Joshi was trained in vitreoretina from European Vitreoretina Training School, Germany, and Rotterdam Eye Hospital, Netherlands. Dr. Joshi also got trained in pediatric ophthalmology and strabismus from Shroff Charity Eye Hospital, Delhi. Dr. Joshi is currently medical director of the Mechi Eye Hospital. He is the general secretary of Nepal Ophthalmic Society also. Dr. Joshi is actively involved in clinicals and academics and has imparted knowledge to many ophthalmologists. Dr. Joshi is an editor of Nepalese Journal of Ophthalmology. He has about 25 publications in national and international journals. A very warm welcome to you, sir. Now moving to our distinguished panelists for the day, Professor Dr. Om Krishna Malla, Professor Dr. Bimal Sinha, and Professor Dr. Basanta Panta. Dr. Sinha is a former head department of ENT, head and neck surgery at IOM QTH Kathmandu. He was the past acting dean at IOM QTH Kathmandu. He was also the past campus chief at Bilgunj campus, TU Nepal. Dr. Sinha was the founder member and former president of the Society of Otolaryngologists of Nepal. He was the president SARC ENT Association in the year of 2010 to 2013. He is also honored by different awards like Lifetime Achievement Award during 10th SARC ENT Congress in 2016 at Dhaka, Bangladesh, and also awarded fellowship by the Society of Surgeons of India, Punjab in October 2017. Dr. Sinha is also involved in various academics and is editorial board member and peer reviewer for many national and international journals. He is also an author and section editor for many books and booklets of ENT and head and neck surgery. A very warm welcome to you, sir. We will be delighted to hear from you. Moving to our next panelist, Professor Dr. Basanta Panta. Professor Panta is the founder and chairman at Annapurna Neurological Institute and Allied Sciences, Annapurna Research Center, and Neuro Foundation Nepal, Maitidhar. Dr. Panta is a past president and life member for Nepalese Society of Surgeons. Dr. Panta is a professor in Department of Neurosurgery at KISS Medical College, Kathmandu. Professor Panta is a founding executive member and vice president at Asian Congress of Neurological Surgeons. Dr. Panta is honored by several awards like first class first position in medical graduation course, 7 academic gold medals during medical training, Gorkha Dakshin Bahu from Nepal Government Social Recognition Medal, and Japanese Ambassador Award for upbringing the relationship between Nepal and Japan. Dr. Panta has paper presentation, more than 300 in major national and international conferences, and has more than 60 peer-reviewed publications. Dr. Panta is also our speaker for a day. A very warm welcome to you, sir. We will be delighted to hear from you. Now, may I request Dr. Chandni Pradhan to proceed for the introduction of our distinguished speakers. Dr. Chandni, over to you. Thank you.
Namaste. I'm Dr. Chandni Pradhan. I'm a glaucoma specialist from Britamur Eye Hospital. So today we have 5 distinguished speakers from different medical fields who will be sharing their valuable knowledge and skills and their experiences regarding this hot burning topic, mucormycosis. Our first speaker will be Professor Dr. Basista Rizal. Professor Rizal is a professor of microbiology in Devdaha Medical College and Research Institute, Rupandehi. He's the founding managing editor of Devdaha Medical Journal, published by DMC and Research Institute. He's also an adjunct professor of Cordially Academy of Health Sciences, Jumla, and a member of editorial board of Journal of Cordially Academy of Health Sciences. He is a member of Infection Prevention Team, Continual Professional Development CPD Unit of Nepal Medical Council, and a council member of International Society of Infectious Diseases. Professor Rizal is also an advisor of COVID Lab Committee of Ministry of Health, and he did his MBBS from Trivandrum University in 1989. He is a registered microbiologist from Canadian College of Microbiologists in 2013. Professor Rizal did PhD from Trivandrum University in 2009 in microbiology, and he did his MPhil from Sri Lanka in 1997. He has more than 100 publications, of which more than 75 are published in index journals. It will be an honor to have him as a speaker today. Our next speaker will be Dr. Urmila Gurung. She is an associate professor in the Department of ENT Head and Neck Surgery, Trivandrum University Teaching Hospital in Maharashtra. She did her postgraduate program from Institute of Medicine in 2008. Dr. Gurung has experiences in all the units of department, namely otology, head and neck, pediatrics, ENT, and rhinology. He has worked as a registrar for the NHS UK for a year and a half under the Medical Training Initiative Program. She is actively involved in the academics of both undergraduates and postgraduates, and she is an ENT coordinator for the undergraduates. Dr. Gurung has several publications in national and international journals, and currently she's working as a section editor of rhinology section in Professor Rakesh Prasad Srivastav's popular illustrated textbook of ENT. It will be an honor to have her here today. Our third speaker will be Professor Dr. Ruth Sanju. As Dr. Malita has already introduced Sanju sir to us all, we all know that Professor Sanju is a very prominent oculoplastic surgeon of Nepal. He is the present president of Nepal Ophthalmic Society, and today he is a chairperson also. Our fourth speaker will be Professor Dr. Basanta Panta. We all know Professor Panta is a renowned neurosurgeon of Nepal. He is also past president and life member of Nepalese Society of Neurosurgeons, and he has been felicitated with various awards in our country. It will be an honor, it will be really an honor to have all the speakers today here. And finally, our final speaker will be Dr. Gentle Sundar Shrestha. He is an intensivist and an associate professor at Department of Anesthesiology at TUTH. He completed his master's degree in anesthesiology from Institute of Medicine. Dr. Shrestha did his fellowship in adult critical care from University of Toronto and European Diploma of Intensive Care and is the Fellow of Neurocritical Care Society. He is the current treasurer of Nepalese Society of Critical Care Medicine, and he has 130 peer-reviewed publications in both national and international journals. Now, I would like to request our president of Nepal Ophthalmic Society, Professor Dr. Rohit Sajud, to give his welcome speech.
Thank you, Dr. Chandani, for a nice introduction. On behalf of Nepal Ophthalmic Society, I would like to make a small remark as a welcome speech here. Dear distinguished guests, speakers, panelists, and delegates, it gives me immense pleasure to welcome you all, speakers, panelists, and participants in this third Nepal Ophthalmic Society's webinar titled Mucormycosis, a challenge in critical practice. A new burden arises with current pandemic health issue of COVID-19. On behalf of society and my own, I would like to welcome Professor Dr. O.K. Malla, Professor Dr. Bimal Sinha, and Professor Dr. Basanta Panta, who agreed to be part of today's event as panelists. In the same way, I would like to welcome Professor Dr. Basista Rizal, Associate Professor Dr. Urmila Gurung, and Associate Professor Dr. Gentle Sundar Shrestha, agreeing to be speakers for today's webinar. As to the future, Ophthalmic Society would like to assist in restoring its past glory and becoming a leading professional body. This is possible now because we have tremendous resources, more than we have ever had in terms of leadership quality and dedication to our profession and for the country. I want to recall our past successful webinars the first Nepalese, the Ophthalmic Society, along with Nepalese Vitreoretina Society webinar held on 28 November 2020 with the title Retina Practice Views from Pioneers, where we had prominent speakers like Dr. Cordially from UK and Manish Nagpal from India. In the same way, we had guest speakers from Malaysia, Bangladesh, and India. In the same way, second webinar on cataract held on 30th January 2021, titled Tobacco in the Hands of Masters, where we have world-renowned speakers like David Chang from US, Dr. Boris Malyugin from Moscow, and Dr. Shashi Kapoor from India. In the same way, prominent national speakers, Dr. Sandhu Purit and Dr. Sagun Joshi. I would like to acknowledge the dedication, team effort of our colleagues, Dr. Purushottam Joshi, who is General Secretary of our society, Dr. Chandni Pradhan, our executive member of society, and Dr. Marita Amate, my co-author in the department, who work hard to make a success to this webinar. I wish you all the best to speakers, discussants, and participants to make a very fruitful interaction for the exchange of skills and knowledge in our practice to overcome this challenging situation of mucormycosis. I do believe we together can win this battle of fungal problem in viral land of COVID-19. Thank you very much.
Now we'll begin our presentation. So, our first presentation will be by Professor Dr. Basista Rizal, and he will be talking. His topic of presentation will be an overview of mucormycosis, a laboratory aspect. Sir, please share your slides.
Thank you, Doctor. I am privileged to be in Nepal Ophthalmic Society as a speaker. Thank you, Professor Saiju and Professor Malla for giving us the society for giving me the opportunity. I will share my slide now, and I will start my presentation. Okay. So, an overview of mucormycosis or laboratory aspects. So, in my presentation, I will be discussing about this opportunistic fungi, introduction opportunistic fungi, and this updated some kind of basic science about the fungi, and this what is mucormycetes, and the clinical presentations of those mucormycosis, and some aspect of laboratory diagnosis, and this discussion. So, this mucormycosis is an invasive disease caused by fungi of the order Mucorales. That is, these Mucorales are present everywhere. So, this common example of these Mucorales are Rhizopus, Mucor, Rhizomucor, Puningamella, and so on. So, this COVID-19 infection has been associated with mucormycosis. So, why it is so, we will discuss later on. So, often seen in immunocompromised individuals like this neutropenic patient and uncontrolled diabetes, common with the patient on this.
Dr. Basista, can you make the full screen, please, your slides?
Okay, okay.
Thank you.
So,
yes, excuse me, Dr. Rizal, can
yes.
you please switch on your video?
Video is not coming?
Yes, sir, your photo is not coming, your video is. Your screen is coming, but your video is not coming, your photo is not coming. Can you please switch on that one?
It is not
Thank you.
coming, I don't know.
It is just next to the mute icon.
This one?
Sir, left order मा left order मा त्यो भिडियो भनेर छ नि स्टप भिडियो भनेर त्यसलाई म्युट र भिडियो सँगै छ त्यो भिडियो अन गरिदिन्छु
ए म्युट र भिडियो है यो आफै आउनु पर्ने हो किन आएन यो चुज भिडियो फिल्टर भन्नेमा जाने कुनमा जाने होला यो
होइन सर तलपट्टि हजुरको स्क्रिनमा क्लिक गर्नु त एकचोटि हजुरले त्यसमा म्युट भन्ने एउटा आइरहेको छ नि त्यसको सँगै नै छ स्टप भिडियो आइरहेको होला त्यसलाई क्लिक गरिदिनु
ए हस् 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 आउनु पर्ने अब
Sir, can you disconnect and reconnect it?
So are you there?
Okay. Yes, yes, yes.
Dr. Batista, you can disconnect and reconnect it now once again.
Okay, okay.
सर ENT बाट सुरु गरिराख्ने कि सर उहाँको कनेक्ट हुन्छ
or we can have it without audio, without video also, audio only.
Yeah, yes, we can have audio only.
Two choices.
Dr. Basista?
I think it's knocked out already.
Dr. Basista अहिले out हुनुभएको छ.
Okay, now maybe we start the next speaker.
Okay.
In the meantime, yeah.
Yeah, can
Yes,
you proceed
sir.
for
That
the
would be a better idea.
formula, yeah, please.
So,
Shall I start my presentation?
yes, so our second presenter will be Dr. Urmila Guru. Ma'am, please share the slide.
I'll share my screen.
Okay. Thank you, ma'am.
Is my slide visible now?
Yes.
Clearly visible and audible, thank you.
Visible and audible.
Thank you, organizer, for
Okay. Can I
शङ्करसँग कुरा गर्यो
डाक्टर वशिष्ठ डाक्टर साहब एकछिन उ गरौँ
अलिकति खोलिराख अब अगाडि बसिराख कतै नजिकै
वशिष्ठ डाक्टर साहब सेकेन्ड प्रेजेन्टरमा बसौँ होइन अनि इएनटीबाट सुरु गर्छौँ डाक्टर साहबले टाइम पनि
हुन्छ हुन्छ हस् हस्
डाक्टर साहब हस् थ्याङ्क यू
On the outset, I'd like to thank the organizers for making me one of the speakers alongside such distinguished speakers. So I'll be talking about what is the role of an ENT surgeon while managing this recent upsurge of rhinoorbital cerebral mucormycosis in post-COVID patients. So mucormycosis initially, before the pre-COVID era, was quite rare, but however, there has been a notable rise in the number of cases, especially in the second wave. Based on the systematic review of cases reported worldwide, India has outnumbered the number of cases of mucormycosis, and unfortunately, Nepal also seems to be following the same path. So we've seen headlines of black fungus spreading all over in India as well as in Nepal. So why is an ENT surgeon concerned about mucormycosis? It is because around 50% of the cases are rhinoorbital cerebral mucormycosis. So, of course, the ENT surgeons have to be involved in the management. So the risk factors for the mucormycosis were always the same pre-COVID, in the pre-COVID era as well, namely the poorly controlled diabetes, mellitus, and the use of corticosteroids. These hold true even in the COVID era as well. So with the onset of COVID-19, there has been a flare-up of mucormycosis cases. It is because COVID-19 itself is an immunosuppressive condition where there is decreased number of CD4 cells, T helper cells, endothelialitis, which help the fungus to go into the tissues and grow there. And alongside that, it causes derangement of the iron metabolism, consequently increasing the number of free iron on which the mucor can grow quite exponentially. And during the treatment of COVID-19, it is quite common to have corticosteroids used as a treatment modality. And alongside that, with patients who've got pre-existing diabetes mellitus, these can lead to acute hyperglycemia. And on top of that, COVID-19 is also considered a condition that can lead on to diabetogenic status. So this can further lead to acidotic environment for which the mucormycosis is a good breeding ground to grow. So mucor is actually present everywhere, and it may be present even in the nasal mucosa as a common cell. And it remains harmless until a person becomes immunosuppressed. So the spores, they enter into the body through the nose, and they tend to germinate within the paranasal sinuses, and then has the tendency to spread to the nearby structures like the orbit and the brain. And typically, the pterygopalatine fossa is considered the reservoir of infection. So as an ENT surgeon, we need to know about the importance of this pterygopalatine fossa, basically a space that lies posterior to the wall of the maxillary sinus, which has communication to different spaces nearby. So here we can see in this picture, it has close connection to the palate through the greater palatine fossa, into the communication to the infratemporal fossa through the pterygomaxillary fissure, through the Vieden canal into the foramen lacerum, through the infraorbital fissure to the orbital apex, through the foramen rotundum into the middle cranial fossa, and the Vieden nerve, the V2 nerve continues anteriorly as infraorbital nerve, which supplies the cheek. So the spread of disease from this particular site is we need to know about this to understand the rapid spread of the disease into different structures and also for surgical reasons as well. So pathology-wise, it has the tendency to invade the vessels that results in tissue infarction and necrosis. So that is the pathological hallmark seen in mucormycosis. So we need to have a high index of suspicion, especially in patients who've just recovered from COVID-19, and also with diabetes mellitus. If they present with acute onset unilateral symptoms, like the symptoms pertaining to the nose and pharyngeal sinuses, like the facial pain, swelling in the cheek region, decreased sensation on the cheek, nasal blockage and discharge, dental pain or loosening of tooth, or eye symptoms like periocular pain, ptosis, orbital swelling, diplopia, proptosis or decreased vision, or there could be discoloration of the facial skin and also on the palate. Or if the disease has progressed quite widely, they may end up coming with the neurological symptoms. So any patients who got this kind of clinical symptoms, of course, would need an assessment by an ENT surgeon by doing an anterior endoscopy followed by nasal endoscopy. We'll have to bear in mind that at times patients may present with these symptoms when they still have active COVID infection. So in such condition, while doing nasal endoscopy, we need to take precautions to avoid being contaminated, as nasal endoscopy is considered an aerosol-genic procedure. So the findings that we can see on anterior on nasal endoscopy are some necrotic yellowish area, or there could be a blackish area which could be on top of the yellowish necrotic area, or sometimes it could be deceiving. The findings could be seen only after removing in some cross or discharge. So it's very important that we suck out all the secretions that we see and assess further into the nasal cavity. And the very typical finding that we see in rhinoorbital cerebral mucormycosis is the black middle turbinate. And also there could be eschar onto the turbinate and also on the adjacent nasal septum. Quite commonly, it's the middle turbinate that gets affected the first, the nasal septum being the second, and the inferior turbinate being the third. And also in early mucormycosis, the middle turbinate or the nasal endoscopic examination may be deceivingly normal as well. So we'll have to make sure that we are not missing anything while examining the patient. Besides that, obviously the eye examination needs to be done, and that would be dealt better by our ophthalmology colleagues. And assessment of the cheek would be necessary to assess the infraorbital nerve anesthesia. And oral cavity examination would of course show palatal eschar if there are any. There could be a decreased sensation over the palate or any infections related with the tooth. So, and if the patient does come with neurological symptoms, of course the neurological examination is necessary. So as an ENT surgeon, if a patient comes to us with such findings, we'll have to proceed with how to manage the patient. And most often, the clinic symptoms are so pathognomonic that we have to start the medications or the treatment as early as possible. But we do send some investigations alongside to confirm our diagnosis. The best thing that we can do is do a punch biopsy, and it's very important that we part of the lesion and avoid the grossly necrotic tissue. So taking a biopsy would of course give us samples for microbiological examination and for the KOH mount and culture, and this has to be sent in a normal saline, whereas the sample has to be sent in 10% formalin. So this on the histology it would indicate tissue invasion and angio invasion, which would be diagnostic for the condition. So there are no blood tests as such to diagnose radiology. So we'll have to order the right radiological investigation that helps us in coming to a diagnosis and also to help us in our surgical management. So there has been a lot of discussion between what we need to choose, but a CT scan and both CT scan and MRI are complementary to each other. But MRI has certain advantages over the CT scan. So this is basically, so the difference can be seen here in the slide. So this is a picture of a lady who had black necrotic middle turbinate while undergoing treatment for some malignancy. So the contrast in our CT scan just shows soft tissue density in the maxillary sinus, the middle turbinate, whereas in the same site with the MRI, which this is a T1 weighted gadolinium enhanced MRI, this shows more information about the soft tissue involvement. So here we can see there's a lot of enhancement in the left middle turbinate, which is the black middle turbinate, which we most often hear about. And there are enhancement of the maxillary sinus mucosa along with the ethmoid. And also the thing that is not seen here in the CT scan, we can appreciate the changes that's in the orbit. So the inferior rectus, the superior oblique, and the optic nerve seems to be enhanced here in the MRI picture. Similarly, in the next slide, in the next CT film, there's not much change that we can see, whereas in the MRI, we can see there's inflammatory changes involving the masticated. So of course, the MRI does give us more information about the soft tissue assessment, and also it helps in guiding us what to debride. So any areas which do not take up gadolinium has to be debrided surgically, whereas the area that takes up the contrast probably may be dealt with the antifungals. So MRI may not be available in all the centers, so at times we just have to rely on the CT scan only. In that case, there are certain findings that can lead or give us an idea whether there could be an invasive fungal rhinosinusitis, such as unilateral mucosal thickening of the maxillary sinus, involvement of the pre and post antral fat, involvement of the pterygomatum fossa, involvement of the orbit without any bony erosion or some subsector ulceration. So similar kind of findings could be seen even in the CT scan of the brain. So from the management point of view, this does not fall into the domain of only ENT. So it has to be a multidisciplinary approach where the management has to be started as early as possible. It is because it has a high mortality rate, as high as 40 to 80%, depending on the site of involvement and also the underlying condition. And if disseminated, this can lead to mortality at a rate of 100%. So any delay in the initiation of the management can have drastic effect on the patient survival. So we can see even a delay of 6 days can double the mortality rate from 35 to 66%. So again, I'd like to emphasize the multidisciplinary approach that is needed for the management of such cases, with each being one of the core team member who would be involved in extensive early surgical debridement. So alongside the extensive surgical debridement, we need to initiate effective antifungal therapy as soon as possible, and also keep an eye on the underlying medical condition. So that has to be dealt with by other specialties. So surgical debridement, as I've mentioned, is one of the key things that needs to be done for the management of the patient. So it has to be aggressive. So why do we need to do surgical debridement? So it basically helps in removing all the devitalized tissue. It reduces the disease burden and also prevents further spread of the infection. And having removed the devitalized tissue, it helps the antifungals to better penetrate and probably have a good outcome out of that. And also it provides samples for microbiological and histological confirmation. So the surgical procedure, the approaches can vary depending upon the extent of the disease. So it could be done endoscopically or via open approach as well. So there have been proposed stages. The recent one being published by Honavar in the Indian Journal of Ophthalmology. So whatever the staging that we follow, it basically helps us in a guide in finding out what all are involved, and also to guide us as to what surgery is needed for that particular patient. So this staging has 4 stages basically. The first stage involving the nasal mucosa, the second being the paranasal sinuses, third being the orbit, and the fourth being the brain. So depending upon the extent of the disease, the surgery has to be tailored accordingly. So we as an ENT surgeon would be involved if the paranasal sinuses are involved, which most often is the case. And the orbit or orbital involvement and the neurological involvement would be dealt by the respective specialties. So I'd like to share a video of a case of a patient that we had operated recently. So this was a 44-year-old gentleman who had rhino-orbital mucormycosis. The MRI had shown involvement of the anterior and posterior ethmoids, the sphenoid, the maxillary sinus, the pterygobaltan fossa, and this was the procedure that we did. So is my video running?
Yes, Dr.
Yes, running.
Running nice.
So basically, in this video, we can see that the middle turbinate is totally necrosed. And what I'm trying to emphasize is we'll have to assess the septum as well, because this may be lurking behind, may remain hidden. So examination of the nasal cavity is very important even during the surgical procedure. So the septal ulceration may at times be missed on the radiological examination. So the ethmoidectomy has been performed in this video, basically the anterior and the posterior ethmoids. So disease clearance from that side also is required. And the sphenosinus also was involved based on the MRI. So I'm just widening the sphenosinus opening, and here you can see this diseased necrotic tissue in the sphenosinus that has been debrided. And so basically to assess the maxillary sinus and also the pterygobaltan fossa, I went through the Denker's approach. So and once the maxillary sinus was entered, the disease from the maxillary sinus was debrided, and the nasal lacrimal duct was skeletonized and later cut flush at the floor of the orbit. And the septum, which was seen to be involved in the initial endoscopic examination, was also debrided. And interestingly, the sphenosinus, the floor of the sphenosinus and the adjacent pterygoid bone also looked necrotic and osteomyelitic, so that had to be drilled away. And I'm just adding on to, this is a video from, separate video from a different patient. So here I'm just trying to show that the medial wall of the orbit can also be decompressed endoscopically if needed. So I'm just removing the lamina papyracea, exposing the orbital periosteum. And finally, once the debridement was done totally, so as you can see, this is the entire surgical cavity where this the maxillary sinus, this surgical placed onto the pterygobaltan fossa, sphenosinus, the septum has been removed, the anterior posterior ethmoids have been debrided, and we did a washing of the nasal cavity, the cavity with amphotericin B, followed by packing of the cavity with Abgel soaked in amphotericin B. So the role of ENT surgeons does not just limit to the surgery itself. So post-operative surveillance is very, very important, because the disease clearance in the first attempt may not be total. So a serial nasal endoscopy is required. which helps us in assessing the state of the surgical cavity and also to take biopsy from the suspicious site. And a re-debridement may also be necessary based on the clinical assessment and also by serial CRP if the CRP does not tend to decrease, and if the serial MRI indicates there is residual disease, we may have to do the re-debridement again. So the number of times of sittings for re-debridement may vary depending upon the disease condition. The use of antifungals actually would fall into the domain of the infection control, but I'd just like to highlight the principle of antifungals here. So the first line of antifungal is amphotericin B, whether it be liposomal or deoxycholate. Liposomal is preferred because of its less nephrotoxicity as compared to deoxycholate. And if the patient do not tolerate or are resistant to these amphotericin B, isavuconazole or posaconazole have also been suggested by the global guideline, which was published in 2019 in Lancet. And after the initial treatment with the intravenous amphotericin B, the step-down therapy is by either posaconazole or isavuconazole. And these drugs have to be monitored by regular blood tests, which as these are quite toxic. And the duration of the medical therapy may vary depending on the person. So it may last for weeks to months or even years. And it has to be continued till 6 months post-resolution of clinical symptoms, the examination also, and also this radiological stability of the findings. And it is still not known yet as to what the lowest dose or the shortest course of treatment is for to be given to a mucormycosis patient. So there have been mention of additional therapies like local use of amphotericin B or hyperbaric oxygen. These are not included in the conventional method of treating mucormycosis, but this could be used as an adjuvant. I'd like to share our experience so far at Trivandrum University Teaching Hospital. We formed a mucor group which comprises of various faculties from various specialities. So far, we've had 8 patients admitted as a case of rhinocerebral mucormycosis, and all of them had COVID at some point, ranging from 1 week to 4 weeks. Most of them are males in the middle age group, and most of them have come from the thoracic region. And the commonest extent is the rhinoorbital mucormycosis. And all of them have fortunately been able to receive injectable amphotericin B. 3 of them have undergone surgical debridement. One had to undergo re-debridement as his symptoms did not quite improve as to our liking. So he underwent debridement just recently, and he's improving. One of the patients left without against medical advice. One of the patients expired because he had extensive rhinoorbital cerebral mucormycosis, and since the prognosis was really poor, operation was deferred. And we still have to wait for the outcomes of all these patients, and till date it seems to be quite challenging to deal with these patients. So treatment of mucormycosis is not easy at all. It takes a lot of, it needs a lot of resources from the hospital side as well as financial, it causes a lot of financial burden. And to note that these are the patients who have just recovered from COVID, which is also a terrifying disease. Prevention is the key to avoid having to deal with such conditions. So the Society of Otolaryngologists of Nepal has a few weeks ago released an advisory which has highlighted the preventive measures of rhinoorbital mucormycosis. And it also has emphasized onto the importance of a treatment that has been used for COVID management. So the judicious use of antibiotics and steroids, the importance of glycemic control is also has been highlighted by this advisory. So with this, I come to the end of my presentation. I thank you all for your kind attention. Thank you so much.
Thank you, ma'am. Thank you for your wonderful presentation. It was very informative as you have covered most of the things that needs to be learned about mucormycosis. Thank you so much, ma'am. Since like we're still having, Professor Rizal is still having some technical issues with his laptop, so I would like to request our next speaker, Professor Dr. Rui Khaizu, to present his topic. So please. So please unmute your mic, sir. Sorry, you sir, you're, okay.
Thank you, Dr. Chandani. So my part of the presentation is we are the warrior for black fungus. So it is. It was in the news from India, but now it became news in our country. So this is the great battle with mucus, and we prefer always life before sight. India and subcontinent are the capital of diabetic world, and so on today, mucormycosis. Thousands of uncontrolled diabetic people are living in this part of the world, and thousands of pre-diabetic people are living unknowing that they are pre-diabetic. So with the COVID era, all these pre-diabetic and diabetic patients became now manifested. The controlled diabetic became uncontrolled, and pre-diabetic became manifested as a diabetic. So this is the one of the scenario for the busting of the mucormycosis in this part. Just a definition, what is mucormycosis? It is a very aggressive, opportunistic, and fatal infection of sinus, orbit, and brain, and affects mainly the immunocompromised patients in home. Post-COVID survival are nowadays in manifestation. In one of the pre-diabetic, pre-COVID era paper showed the incidence of rhino-orbital mucormycosis in diabetic people is 0.15%, but the sudden increase in number is going on. That's why there will be another figure will come out after some time. So in clinical presentation, look at the clinical presentation. Most of the presentations, okay, sorry. Okay. So my colleague said I have to speak loud. So among the clinical presentation, most of the presentations are related to the ophthalmology or eye or around the eyes, like patient come with the ocular pain, one-sided facial pain, facial swelling, conjunctival congestion or chemosis, and this could be the white eye also if it involves the apical part of the orbit, complete ptosis, little bit proptosis, not much, and diplopia, double vision, seeing, and loss of the extraocular movement, and abnormal pupillary reactions, blurring of vision or sudden loss of the vision. These all involving the orbital apex or the apical crowded portion involved by the fungus will make all these ophthalmic manifestations. In the same way, periorbital necrosis and loss of sensation along the trigeminal nerve passing through the orbit. So looking at this, the mucor patient will come to the ophthalmologist probably before going to the ENT. That's why we have to know that this could be not the eye patient only, this could be the combined patient for which we have to entertain together. Coming to the investigations, so diagnostic endoscopy with tissue biopsy and staining with the KOH and calcoflower white is the first step looking at the suspected cases. So biopsy, microbiopsy is preferred now. You don't have to take big chunk of the tissue. And with the endoscopic navigation of the nasal mucosal cavity, you can take the suspected part, small piece, and send immediately, and it will give the relatively quick response from the histopathology colleague. Tissue culture for the fungus will take some time. And another very important investigation we have to do is radio imaging. I'll talk a little bit later about this. And routine blood tests, including the blood sugar and liver function and renal function test, status of the PCR, and relevant cross-consultation with the neuro, ENT, MaxVax, radio, endocrinology, and internist. So one of the tests we have to know as rhino-orbital mucormycosis has divided into minimal involved orbit and diffusely involved orbit. In retropulsation, you just press gently the eyeball toward the orbit. If you feel that it is going in and coming out, so that is a normal one. When you push the eyeball, it doesn't go in and resist your finger with some hard feeling, some feeling of the stony hard. That means retropulsation is resistant. So this is a very important sign. We'll come to talk about this later. So in imaging, I would just supplementary some of the slides with Dr. Urmila we described here. The contrast enhanced MRI is the preferred one. It will give the variable T1 and T2 intensity, and it will delineate the devitalized mucosa, and which is known as a black coordinate sign when the navigating the nasal mucosa. You will see the necrotized, this turbinate will show in the MRI as a non-perfusion or hypointense area in the nasal cavity, and it will not, because of the lack of the contrast pickup, it will look like a hypoperfusion area, and which is known as a black turbinate sign, which is a very important sign to suspect the mucor. In paranasal sinus, mostly the opacification and or the fluid level you will see, or thickening of the mucosal lining will be seen. In the orbit, early opacification of the middle wall, as the sphenoid sinus is the one of the port coming to the orbital content, and as well as the nearest muscle is the middle rectus muscle thickening is visible. In advanced cases, diffuse opacification with the involvement of orbital apex is visible. Cavernous sinus thrombosis usually is hyper-intense lesion. You will see where most of the cases orbit involving the cavernous sinus. So here, in the left-hand side, there are the CT. In the first one is the bone window showing the minimal inflammatory lesion here. You see all the swollen soft tissue, but when you look at the soft tissue window, this inflammation is more prominent. Like here, you will see this thickening of the middle rectus muscle as well as the other muscles, and the wall of the middle wall of the orbit is involved completely, and there is a small defect of the middle orbital wall through which the sinus extend infection to the orbit. In the right-hand side, you see the coronal view of the MRI of the orbit and paranasal sinus. Here also, you see the maxillary antrum has opacification and thickening of the lining, and you will see much more better view in compared to the CT. There is a inflammatory process going on through the sinus to the orbit. In the contrast, the contrast pickup is better, showing the more prominent inflammatory changes going on in the sinus and as well as in the orbit. In mucor, we know that the pathogenesis is the angioinvasion causing the occlusive vasculopathy, making the ischemia and the necrosis. So in the left-hand side, you see the dilated vein. This is the superior ophthalmic vein, which lie laterally in the posterior aspect of the orbit, and it crosses over the optic nerve and lying the medial aspect of the orbit. And this vein has fungal infiltration, and you see that there is a thrombus. Actually, this is the thrombus formed by the fungus, not the blood clot. The fungus making the ischemic changes, and you see here the ipsilateral side of the cavernous sinus has also involved. In the contrast enhanced of the same axial view of the CT is showing that the inflammatory changes has much more prominent. It is coming through the ipsilateral ethmoid sinus as well as sphenoid sinus, and the posterior half of the orbit has involved here. The role of CT, I fully agree that CT will supplement the MRI basically bony landmark can be better traced with the CT scan. It is not well visualized in MRI. We know that we need the ENT navigation for the mucosal debridement. The bony landmark of the orbital wall is very important. At the same time, hard palate and other bony landmarks have to be considered during the navigation and debridement. And for the orbital surgeon, the plan for the exenteration, we have to know the bony condition, whether it is eroded, it is involved, defective, and how to proceed or how to make a clear plan for the exenteration. The imaging feature in the mucormycosis, as we mentioned, that black coordinate sign, this is one of the hallmark in the MRI, where non-perfusion part of the nasal mucosa will show as a hypointense area. For example, here you see the fungal infiltration in the ethmoid ear cells involving the middle half of the orbit, thickening of the inferior rectal muscle, middle recti, as well as the superior middle portion of the orbit is involved. And here the turbidity is clearly visible. Here the hypoperfusion. In the same way, in this coronal view of the right side of the orbit, also showing there is a involvement of the frontal sinus, ethmoid sinus, as well as the middle half portion of the orbit. So another specific characteristic of the MRI in the mucor is fat stranding. That's the attenuation of the fat. In the right side, you see the normal fat volume, looking at the hypo intensity. In the left hand side, in the right hand side, you see there is a stranding of the fat with the infiltration of the fungal effect, and so in the involvement of the ipsilateral cavernous sinus. In the extensive orbital involvement in the mucor, you see the very typical sign. As you know that in the right orbit, you see the contour of the eyeball should be like this, and the retrovulvar area is normal here. In the left-hand side, you see the increased pressure intraconally in that orbit will push the eyeball extremely anteriorly, and stretching all the structure, possible structure like the medial rectus muscle, lateral rectus muscle, and the optic nerve has tented anteriorly forward and making the distortion of the eyeball, and this is look as a conical shape of the eyeball, which is known as a guitar big sign. And here, intraconal space is fully occupied by the fungal inflammatory contents or fungal abscess. In the right-hand side, with the same picture, you see the contrast enhancement. You see there is a hyperintensity in the infiltration, inflammatory infiltration area involving the ipsilateral cavernous sinus area. In the same way, this portion, the whole entire orbit, is not picking up the contrast because these are the non-perfusion area and showing in the MRI as a hypointensity. So this is all the devitalized tissue filled up with the pus or necrotic tissue. So this is very important to know. And here, I'm just overlapping the classification given by the Indian Journal of Ophthalmology. This is very the first classification came up, and which is very good for the planning and diagnosis. They have classified in stage 1, 2, 3, 4. Stage 1 for the nasal cavity involvement, 2 for the paranasal sinus, 3 for the orbit, and 4 for the brain. In involvement, the orbit is further divided into 3 A, B, C, and D. In A, nasolacrimal duct and middle orbit is involved, but the vision is not affected. Still good prognosis here. In B, there is orbital involvement more than 1 quadrant or 2 structure, but still vision is unaffected. In 3C, there is a diffuse involvement of the orbit with the central artery occlusion, ophthalmic artery occlusion, and superior ophthalmic vein thrombosis and involvement of the superior orbital fissure, inferior orbital fissure, orbital apex. And here the vision has lost, and this will give the orbital apex syndrome manifestation with the diplopia, ptosis, frozen eyeball, and paresthesia along the B1 and B2 nerve. If the both orbit is involved, then it is a bilateral involvement, and so on the sign and primary assessment. Primary assessment is for all stages is the same. Diagnostic nasal endoscopy mandatory, and contrast enhanced MRI preferably is the first diagnostic tool to put or come up with the complete diagnosis. And I had very few experience with the current mucormycosis scenario in Nepal. I had a chance to entertain with only 2 cases. This is the case last week. I enucleated, came with the cases of as a panophthalmitis. 15 days back, he suddenly developed ptosis and pain in the left eye, and with protrusion. Then he had the history of stroke, but no history of COVID, no history of steroid use, and no history of the diabetes. And surprisingly, it is very suspicious to me that this looked like the fungal infection, as this patient came from the thyroid region. And during the enucleation, we planned for the enucleation. During the enucleation, it was surprisingly, it's almost bloodless, because all the ischemic tissue inside the orbit didn't make much discomfort him. At the same time, I didn't use much cautery. And behind the eyeball, I found there is a pus, and there is a devitalized tissue and stranding of the fat, necrotizing fat. And interestingly, his CT scan is very much similar to the CT scan given in the reference book. And there is a disfigured conical shape of the eyeball because of the immense pressure inside the intracorneal space in the orbit, making the guitar with sign. And there is an involvement in the soft tissue in the lid at the same time. In the corneal view, you see the facial portion also involved in compared to the right, left side has involved much. And his investigation showed that sugar is 170 milligram deciliter normal, and his KOH staining is negative, high creatinine C, and his CT scan showed that the thickening of all layer of the eyeballs and surrounding fat stranding, hyperdense aqueous and vitreous humor, periorbital soft tissue thickening, considering the left panophthalmitis with surrounding inflammatory changes. And during the surgery, you see these are the tissue. I couldn't take out the eyeball completely intact because there was a lot of adhesion, and I just took out in piecemeal. And these are the fat and other tissue came out like this. It is very unhealthy and necrotic. And after the suturing, the healthy tissue looks like this. And within few days, I got the histopathology report of the enucleated tissue, and it gives the very definite clue for putting the diagnosis of mucormycosis. So section showed necrotic fiber adipose tissue with non-septed wide-angle branching fungal hyphae, which is very classical to mucor, and past positive suggestive of the mucormycosis. So this patient has referred to the university hospital for further treatment, but I presume that he is in very bad condition as he is in the diffused involved orbital stage of stage 3A, and the prognosis of this stage is not very good. And this is the second case I entertained also last week. This is one of the relative of my colleague, Dr. Ili, 67 years old female from the Kathmandu, a known case of the hyperglycemia recently detected during the COVID time. COVID positive case was on the steroid and COVID treatment for some time. And for a week, suddenly developed ptosis, proliferative proptosis, and red eye, and ophthalmoplegia. Couldn't make movement of the eyeball. And I got the CT of this patient, and I found there is the extensive inflammation of the ethmoid in the right eye. And same way, there's involvement in the superior medial portion of the orbit involving, including the medial rectus muscle thickening. In the axial view, you see there is an involvement of the posterior part of the orbit, apical portion of the orbit, making the orbital apex syndrome, and it looks like it is spreading toward the cavernous sinus and further. And I requested to do MRI to just see the clear delineation of the normal and abnormal tissue beyond the cavernous sinus. And we wouldn't get that, and very sorry to say that this morning this patient has passed away. For the very simplified way to understand the orbital involvement by mucor, it is divided into minimally involved orbit and the severely involved orbit. For the minimally involved orbital mucormycosis, there is no resistance to the retropulsation, so you can push the eyeball very nicely inside and coming out spontaneously to the normal position. And there is no extraocular movement restriction. Vision is present, and orbital imaging suggestive of limited disease only. in the diffusely involved orbital mucormycosis, there is a significantly positive electroporation. That means you cannot push the eyeball inside the orbit because there is a big resistance of the fungal mass. And frozen eyeball, you will see with any eye movement, you will elicit loss of vision and extensive orbital involvement. And this is we have to know that for the management perspective. And as we knew that management is the multidisciplinary, we need the team. One single person cannot do successful management for any patient. And should be started medical and surgical as basis of emergency way. The early 6 days, known as a golden window period for diagnosis and treatment. If beyond 6 days, the prognosis or mortality of the disease will double. And the team has got the different subspecialty, and in the management, absolute control of the diabetic and control the ketoacidosis status, and start amphotericin B immediately in all suspected cases. I'm not saying the diagnosed cases. Suspected means you see the clinically, and in your ENT navigation of the nasal mucosa, you find some suspicious, and then radio imaging, you see the suspected sign, then just start the amphotericin B without confirmation from the microbiology and histopathology. Sinus debridement depends on the site and extension of the disease, facial debridement, maxillotomy, exenteration. These surgical manipulation to be done accordingly. So for the diagnosis, the Indian Journal of Ophthalmology has published recently the article, the orbital mucormycosis is divided into possible, probable, and proven. In possible, you will see only the signs, symptoms, and you just observe for some time. Every day, in 24 hours, you observe. If you progress, then go for the probable diagnosis management. In probable, you see the clinically undiagnosed nasal endoscopy suspicious lesion, and in MRI or CT, you see the contrast enhanced suspicious lesion like the black turmeric sign or some other signs. In proven, this is microbiologically and histopathologically proven cases, and confirmed cases, you will manage accordingly. So I'll skip this slide, as Dr. Urmila has already shown that the mainstay drug for the mucormycosis is the amphotericin B. The dose is 5 to 10 milligram per kg per day, 5 milligram for orbital mucormycosis, but 10 milligram when brain is involved, dose will be the double. And duration is recommended for 4 to 8 weeks, as this is a toxic drug and very expensive. So 2 weeks is mandatory, and then you can, according to clinical radiological response, switch on to the pasaconazole. And adjunctive therapy with the pasaconazole as a 300 milligram tablet twice a day in day 1, and then once a day for 3 to 6 months. And during the treatment with these drugs, you have to closely watch the renal and liver function and the blood sugar level. In the minimally involved disease, we have to closely observe the patient and observe the sinus with the limited medial wall debridement can be done. Exenteration only performed when the disease progresses to the further stage. And retroborough amputation B in alternate day or in subsequent day for the 7 days also recommended. The transcutaneous retrobulbar amputation B injection is given like it is adjunctive therapy in progressive mucormycosis, where the preventing the penetration of systemic antifungal to the devitalized tissue in order to stop the progression of the further devitalization around the healthy tissue. It is indicated this 50 mg vial of amputation B is diluted with 14 milliliter of the distilled water will make 3.5 milligram per ml. And this 1 ml reconstituted solution is given as we give the block during the mini ophthalmic surgery in local performing, superomedially or infromedially, or as recommended according to the site of the involvement. And this can be given every day for 7 days or every other days also 7 days. But long-term use of the retrobulbar amputation B is in the question, whether what are the side effects and what is the therapeutic effect we can get. It is just recommended for 7 doses. And this is the figure showing that the first, along the floor of the orbit, you just prick the needle 1 centimeter, and then they change the direction of the needle upward and medially inward. So you enter the retrobulbar space, and where the most of the fungal elements are residing, you push there to get the proper effect in the right side. In the advanced orbital disease, systemic amputation B to start immediately and aggressively and repeatedly debridement of the necrotic tissue to be done in nasal cavity and sinuses, and exenteration in most of the cases have to perform. And the exenterated socket is irrigated with 1% amputation B in the daily basis. So this is one of the guidelines published by RP Center AIMS, and to identify the high-risk patient and looking at the symptoms to classify and management properly. So why rhino-orbital mucormycosis is common in second wave? It's very interesting. In the first wave, we heard in the news that about 40 cases was reported from Gujarat and about 10 cases from Maharashtra and Delhi. But now every day we are hearing that hundreds of cases are coming up from India, different cities. The reasons are presumed that the COVID-19 cases number itself increased in compared to the first wave. That's why they increased the number of mucormycosis is possible. In second wave, the use of steroids and other immunomodulators like tocilizumab and antibiotics irrationally. The early start of the steroid for prolonged use more than 2 weeks, not in the right time, used in high dose, and it is not well monitored by the practitioner, making the misuse of the steroid. Steroid is not recommended more than 2 weeks maximum, and standard dose is 7 to 10 days. And another, the COVID-19 has broken mucosal immunity of the mucosal lining of nasal cavity, oral cavity, and proximal portion of the respiratory and gastrointestinal tract. It is already published in some of the paper that mucosal immunity has broken by COVID-19 virus. And steroid is indicated only when the hypoxia less than 74% persistently, or the persistent fever more than 5 days, where the high inflammatory marker has showing the cytokine storm. It is a specific indication for the steroid. And other reason why the mucormycosis have flared up in this time, because of unhygienic or contaminated use of oxygen therapy, probably industrial oxygen in use instead of the medical oxygen. Status of diabetes had not controlled. Pre-diabetic became manifested well diabetic uncontrollably, and diabetic became uncontrolled and ketoacidic form, making the low immunity itself. And the water used in the dehumidifier did not change. The tubes and pipes mass are not changed in every patient. So these could be the possible reasons why the mucormycosis are flared up today. Exenteration, this is a mentally and physically very vulnerable disease, and we are very unpleasant to perform this surgery, but life first sight. So to preserve the life of the patient, we have to sacrifice eye of the patient. It is indicated, there is no consensus universally. Still, it is in debate whether exenteration to be done or not, because the outcome of exenterated and non-exenterated patients almost same. So exenteration is indicated to halt the progression of the disease, and in the diffuse orbital involvement, and only the mucormycosis involving the orbit only, or minimal cavernous sinus involvement, it is indicated if the progress of the disease is not improved with the conservative management in 72 hours, and only one orbit is involved. In those cases, it is indicated. It is not indicated in bilateral involvement in cases of intracranial extension, or in the orbital apex involvement only. If the anterior part of the orbit and middle portion, middle 1/3 of orbit is not involved, an apical portion would be involved, is not indicated, because through the pterygopalatine fossa, the infection can directly spread to the apical portion without going through the sinus. And this type of manifestation can be well managed with the conservative management, the amputation B systematically and with retrovalvular injection. So can we prevent the mucormycosis? Yes, we have. Here is some points given: judicious use of the systemic steroid and tocilizumab and other antibiotics, aggressive monitoring and absolute control of the diabetes, and following the aseptic precaution in the handling, personal hygiene, and betadine gargle, and all-time mask using, and prophylactic oral pasaconazole in the high-risk patient can be given to prevent from the mucormycosis. And for the post-COVID survival patient who are in the risk factors, with the routine physical examination, we can do the simple test like this. Everyone can do the vision test, pupillary reaction after motility, sinus tenderness, and look at the palate and nasal cavity to see the any scar. A nasal swab for the KOS mount and culture at the bedside procedure can be done in the any setup. So these are the things where you can find out the positives. Things can suspect and manage accordingly. So words of the wisdom, absolute control of diabetes, everyone is emphasized, so diabetes should be controlled well, and regular visit the post-COVID survival to eye and ENT doctors by patients for the mucosa of the nasal cavity and oral cavity to check. It is recommended that 1% betadine gargle twice a day can prevent mucor. 0.5% betadine nasal wash can prevent the portal part of the nasal cavity in the body. Saline wash of nasal cavity. Saline can moist and make healthy the nasal cavity mucosa, but it is not ensure that the mucormycosis can be stopped. Another is amputation B, 3% ointment is available. You can put in the nostril twice a day, can also prevent the portal portion for the mucor. And all-time mask, personal hygiene improvement is very, very important to follow. And we should be watchful for at least 6 weeks post-COVID, because this is the very risky time. And early catch-up, making the minimal intervention. So this is one of the largest publication in the post-COVID patient, including 929 reported cases. Before the conclusion of this paper is saying that before amputation B, 90% or more mortality was recorded, and today's also with treatment, the mortality rate is 50 to 80% is still continuing. And this study is showing that if you use amputation B alone or medical management alone, about 60% survival is there. If you treat with surgery alone, another 60% about you can have the survival for your patient. When you combine these two, it will reach more than 70%. So it is recommended that the treatment for the mucormycosis should be medical and surgical together as an emergency basis. So now come to the take-home message. Ophthalmologist may be the first physician to handle the cases, as most of the symptoms are related to eye or periocular tissue. And always you put the first differential diagnosis as a rhino-orbital mucormycosis, as the delay of the diagnosis can be fatal with bad outcome. And aggressive medical and surgical management should be initiated with multidisciplinary team and counseling for the family on the prognosis, as the medical legal cases and other stuff can come together to prevent this. The proper counseling should be there. So we all are doing some. Keep it up. Thank you very much.
Thank you, sir. Thank you, sir, for your wonderful and elaborate presentation of mucormycosis from ophthalmological perspective. So now we'll move on to our next presenter. Our next presenter is Professor Dr. Basanta Panta. Sir, please share a slide.
Is it visible?
Yes, sir. So, but you have to enlarge. You have to enlarge the screen.
Yeah. So first of all, I would like to thank the Nepal Ophthalmological Society colleagues for bringing up this topic. And when Dr. Soizo asked me to talk about it, I said, I don't know about it because I've not seen a case, And so he was insistent that I should speak about it, even though I have not seen this. So I have done some of my study and some of my experience, and would like to share with our colleague.
Let's first talk about who is the expert of COVID in this country, Who should be the expert? Is it a virologist, or is it a immunologist, or is it a chest physician? And so I don't think anybody is an expert in COVID, because it has been, just around for a very short period of time. And whatever knowledge that we have accumulated is within this period of time, So I don't think anybody can call themselves an expert in COVID. And again, who is an expert on black fungus? Unless the publication in Indian journal and Indian media, we are completely unaware of this disease that existed. But then suddenly this became a big awareness to us, and then now we are sitting here and talking about seemingly so important topic, and with a very, very high mortality and morbidity. And I can see that we are actually being prepared for the, the bigger wave of problem that might arise. And just give you this MRI. This is not my patient, but I had a similar, exactly the same. This is a mucormycosis patient. By the way, the R is silent, so it's pronounced as mucormycosis. So, and the patient came to us with exactly the same pathology, and I didn't know what it was. And so I asked them that they should get it biopsied by some kind of navigation or some kind of stereotactic system, And the patient didn't turn up, and I don't know what happened. But recently we have been seeing funny type of MRI images time and often. And this can be either a black fungus or any other fungus that we have not talked or we have not discussed, because we are only talking about mucormycosis, but there might be other fungus infection which we may be dealing with. Just to give you a few examples of recently operated cases in our institute. The left one is T1 weighted plain MRI, where you can see that there's a little bit of edema there, otherwise looks normal, and a little bit of infiltration in the ethmoid sinus, and maybe the pituitary fossa is a little bit inflamed. But if you do enhanced MRI, then you can see that this is clearly the dura, and extradurally and also intradurally there's a funny enhancement. And these are the coronal pictures, and also the cavernous sinus is also involved. So we thought this could be some kind of fungal infection, but this patient didn't have COVID infection as such. But remember, many of the COVID patients may have subclinical infection. So they may not have a very virulent infection, but they may have a subclinical infection. So we suspected fungal infection, and we operated. There was no tumor. It was, very much granular sort of whitish discharge-like thing, and we tried to remove as much as possible. Most of the lesions were extradural, and when we asked for KOS staining, it came out negative, and they didn't say it's a fungal infection, but they said that it's a granulomatous chronic inflammatory disease. So we don't know whether this is actually some kind of fungal infection or not. And this is a patient that I operated 2 days ago. It's a nurse by profession. And she came to me with bilateral papillitis and a very much choked disc on both sides. Left is more than right. And she's completely blind on left side. And there was, features of sort of orbital apex syndrome sort of features, And you can see that there is involvement of the cavernous sinus, and then extension into superior to the sella, and this is the optic nerve which is being lifted up. and that is the sphenoid sinus is totally infiltrated, and there is a dural enhancement as well. So we also suspected this is an inflammatory lesion, could be fungus. Operated on the lady, there was no tumor. The whole thing was epidural, and surprisingly, the optic nerve was very, very swollen. And since the lady had no perception of light on left side, but questionable. Sometimes he says, I may be seeing from the temporal aspect when we did a pinpoint projection of light from the temporal area. So we took out as much as possible the lesion, and then we did a vertical slit of the optic nerve. This is the first time I ever did a surgery like that, where I cut the optic nerve, and then there was this this exudation that came out from within the optic nerve. And actually, her vision on the left eye also improved post-operatively, because the optic nerve was being compressed from within, because of the inflammation. So we are waiting for the histology, and this could be another funny type of inflammation. So we are seeing this kind of, not very usual, very rare sort of presentation these days. And so now I come to mucormycosis. This is black fungus, Calodouci, and this has been known since a long, long time. And it's quite common fungus, but then it doesn't affect people. It's a kind of a commensal in our body, especially on the nasal cavity, as our previous speaker has said, especially elaborated by Dr. Guru. And so once we are immunocompromised, then these fungus affect us. So there's a lot of problem with, again, nomenclature, but rhino-orbitocerebral. I like this, chronology, because it starts from the nose and then goes up to the brain. It can affect the cutaneous only, or pulmonary only, gastrointestinal, disseminated. And isolated cerebral mucormycosis is extremely rare. I just got one paper from Korea where they have said there's an isolated cerebral mucormycosis. And actually they could treat this patient, and the patient survived. So probably Dr. Basista will be talking about the fungus itself. But this is, there are other genera of, we should know that there are other genera within the fungus as well, and some may be more virulent than the other. So this we have to know. This is not only one fungus. This is a group of fungus. Epidemiologically, it's not very common, about 10,000 people all over the world annually. And it's much higher in India. And if you have a diabetes and if you are immunocompromised, especially with COVID infection, then the chance of having this is pretty high. And the symptoms are mainly, orbital, facial, temporal, headache. And so the first presentation the first case that I showed, a male who had a facial pain, if it's only one side, we think about trigeminal neuralgia, but he was having severe bilateral facial pain. And so other risk factors include IV drug users, malignancies, HIV/AIDS, organ bone marrow transplantation, chronic kidney disease, liver cirrhosis. And there are about 20% of patients who don't have any underlying immunocompetent, they are immunocompetent patients. So we have to consider that as well. How this virus get into our body? Mainly through inhalation, and they go and sit in the mucosa, especially the nasal mucosa. They can be ingested and go into the digestive system. And the spread, as Dr. Guru has very nicely presented, that it spread locally through the nasal cavity or different nasal structures into the cavernous sinus or to the brain. And so once it has invaded, there is a cross reaction with iron molecules, and then it becomes, invasive to the vessels, and through vessels, it disseminates to the whole of the body. That's why, although it's a local disease, the patient die of, systemic infection. It's not a local infection that kills a patient, but it's the systemic spread of the infection that causes, death of the patient. And this has been said many, many times. It's sometimes nice to be the last speaker because everything is already said, but then sometimes it's bad because you don't have left anything to say about it. But now, if you look at the route of entry, then, since it's a nasal cavity that they enter, so obviously the nasal cavity and the paranasal sinuses are the one that is involved first, and then it can go to the orbit, as Dr. Soizu has very nicely elaborated, and through the blood vessels or through the cavernous sinus. Once it gets into the cavernous sinus, then it can go into the both of the orbit again, or it can go into the brain. So again, I think we are repeating the same thing, but then the infection generally starts from nasal mucosa and sinuses, invades the orbit, and then into the cerebral involvement through or ophthalmic artery. As you have seen, angioinvasion is quite common with this fungus, or through subarorbital fissure, or through the cubiform plate, where there is actually, the olfactory nerves that goes through the cubiform plates to the intracranial structures. So there is actually a highway from where you can actually, the infection can travel to the brain. How do you study these cases? Both you can do a CT MRI, as my previous speakers have said, but obviously MRI will tell you much better information. And you are looking at the invasion into the, you are trying to look at the angioinvasion. You are trying to look at the bone destruction or necrosis, a soft tissue involvement, and intracranial involvement. Some of the pictures that I want to show, this is an enhanced CT scan where you can see that there's a low density area with a ring enhancement, and then perilesional edema. So this is you can take it as any brain infection or a brain abscess, but then this is a case of a fungal infection, or it can invade into the ethmoid sphenoid sinus, into the cavernous sinus, into the orbit, and into the supraorbital area, where there is not much of enhancement of the fungus itself, because the fungus itself doesn't have vasculature, and so this looks black, and the rest of the inflamed tissue looks enhanced. And if you look at the MRI, then you can see that there is an invasion of the fungus on this side, and on the other side there's a lot of inflammation of the turbinates and also the maxillary sinus, ethmoid sinus, and you can see that there is inflammation within the brain, so it has extended into the brain. So this is the route any of the infection takes place, and this is from the nose into the brain, and this is the route, probably in this case through the cribriform plate into the brain. Again, you can see that the extension of the fungus, and then lot of inflammation around it. So this is enhanced, whereas the fungus itself is not enhanced, and that's the enhancement there that you can see. And sometimes you can see the carotid artery, the wall of the carotid artery is also being enhanced quite well. And everybody has talked about black turbinate sign, and most of the time when you give gadolinium enhancement, the turbinate enhances because there's a lot of perfusion there, but with the invasion of the fungus, it looks black, so you don't see that middle turbinate being enhanced. And so that was a similar case that I saw last time, and this patient also have orbital fungus there, and then also into the cerebral peduncle. Probably it went there through the bloodstream. And if you see here, then the cavernous sinus after enhancement should look white, but here it is black. This is the normal side, which looks okay. And actually, the carotid artery wall is much enhanced than normal. If you look at the normal side, then there's no enhancement of the carotid wall, carotid artery wall. And they can present with infarction like this when there is an involvement of the carotid artery. And these days, we are also seeing some funny type of strokes, and we are always discussing why they are presenting like this. Like in this case, I mean, very high suspicion. There should be a very high suspicion to actually say that this is a fungal infection. Otherwise, most of these patients we will just say this is an infarction and treat accordingly. So you have to have a real high degree of suspicion in these cases. Some of the cross sections of the brain with involvement of the fungus, they actually look black. And so, as I said, we should have a very high index of suspicion, especially with immunocompromised patient and COVID survivors and patient on diabetes and patient on anti-cancer medications and so on and so forth. And if you can do early diagnosis and start antifungal treatment with or without surgical intervention, then they will have some chance of survival. But if there's a dissemination of the infection, then the chance of survival will be very low. Imaging doesn't help that much. Actually, you can suspect, but you cannot say anything about image. So it has to be, and CSF analysis doesn't help as much. KOH, you may be able to see with KOH, immediately you can see what is happening, but generally we don't do fungal culture, but it takes a long time and it will delay the treatment. So the most important would be a tissue biopsy, which will show something like this, a branching fungal like this. And you can also do a molecular study like PCR for confirmation and for species identification. So the most important thing is early diagnosis, and that means a very high degree of suspicion, because they may pass by just like a cerebral brain abscess or tuberculosis, or you can just miss it. So you have to have a very high degree of suspicion. And if there's an underlying predisposing risk factor, then there's a high chance that these are a candidate of mucormycosis, and the surgical debridement with antifungal therapy would be the treatment of choice. And this has been, again, talked, amphotericin B, and if this doesn't work, then other antifungal can be used. And there are a lot of people who do not tolerate amphotericin B, so we might have to go to a lesser potent antifungal drugs, but all of these has to be given IV. And the ENT, our Dr. Gurung has very nicely said, and Dr. Soiju has also said, whenever you suspect antifungal, then cleaning that area, soaking that area with amphotericin B. Actually, this has remind me again that I should do it whenever there is a very high degree of suspicion. I should do it, before the diagnosis also comes. And this is the lesson that I've learned today. And complications, you can have cerebral abscess, any invasion of the arteries, angio invasion can lead to infarction, or it can bleed. A cavernous sinus thrombosis and leads to bilateral ocular presentation and blindness, like the case that I've just presented. The prognosis is pretty bad, and about 70–80% of the patient do not make it, but it depends on what is the extent of the infection and how soon you could identify it. So it's a case to case. So mortality will depend on where was the infection and how severe was the immunocompromised status of the patient. So I'm coming to the end of my presentation. We were thinking that black fungus is not to be worried. This is not our problem, but then suddenly we started having, a lot of patients with the black fungus. Some of the news cuttings that I have put here, we have detected in first there was 10 cases that was reported in Tarai region. So in summary, I would like to say that it's uncommon, aggressive, and necrotizing infection, and the rhino or bitocerebral mucormycosis, and that is the chronology most of the time they follow, and radical surgical debridement and antifungal therapy, correction of underlying metabolic problem or impaired immunological status should be controlled. Especially the blood sugar has to be controlled. But then most of these patients, when there is a chest infection, you are treating them with very, very high dose of steroid, and that is the time they will get this problem. So again, I would like to thank everybody, especially the ophthalmic colleagues. Hope we will be able to meet in person again, like the good old days. Stay safe without being terrorized. We are being too much terrorized, I think, and we should not be terrorized. And we need to relearn to live. I think this is the time every walk of life, whether it's a medicine or a business or whatever, we need to relearn to live together with COVID, because it's not going to go away very soon, and we will be seeing more and more new diseases. So we should keep our eyes and ears open, not only to black fungus, but other commensals that may infect us. Thank you very much.
Thank you, sir, for sharing your valuable knowledge and experiences in black fungus. Now, before we proceed with our last presentation, I'd like to inform that Professor Vasistha Rizal will not be able to present today due to some unavoidable technical problems. So we are very sorry about that. However, we are now coming to our last presentation of today's webinar, and it's by Dr. Gentle Shrestha. Dr. Shrestha, please be ready with your slides.
Thank you, Dr. Sandy. Is my slide visible?
Yes, yes, it is visible.
And I'm audible as well?
Yes.
First of all, I'd like to thank the Nepal Ophthalmic Society for conducting this very timely and important webinar and providing me this opportunity to talk about mucormycosis from the critical care perspective. I'll try to be very much brief and concise because many of the things are already discussed by our previous esteemed speakers already. So I have no conflict of interest to declare. And also a quick overview. Most of those might be just the repetition of the things that the previous speakers have already mentioned. As you know, it is very much progressive and destructive disease, mucormycosis. The mortality is very high, 40 to 80%, especially if more the extensive the involvement, the higher the mortality, especially if there is CNS involvement, the mortality is even worse. So it is very important to reach the diagnosis on time. And one important thing I'll be discussing later on as well with some data as well, and that is that the mucormycosis is more common in the patients that are admitted in ICU as compared to those who are managed at home or in wards. So that can be one important aspect that the critical care physicians should think of. And regarding the diagnosis of these patients in ICU, the diagnosis can be a little bit more challenging because most of the patients, they are on organ support, they are intubated, mechanically ventilated, they are on various medications, including sedatives, analgesics. And we often prone the patients who are hypoxemic. So it's very likely that we might miss the early signs of mucormycosis, like the facial swelling or swelling of the orbit. That might be missed. We might consider it because of the proning or because of various medications or general edema or so on. And various symptoms that the patient might otherwise would have expressed or mentioned, and that might not be mentioned by the patients who are intubated or sedated. Definitely, we need a multidisciplinary approach for this very important disease. and combined medical and surgical intervention would definitely improve the outcome. And as a critical care physicians, we might be in a position to collaborate for this multidisciplinary interventions and early imaging that can definitely help in early diagnosis and go for the definite plans. Moreover, we have seen how challenging the management of mucormycosis can be, ranging from the medical management, the extensive surgical management that might be necessary, including the need of some very disfiguring surgical procedures like exenteration. And in the places like ours in Nepal, where we have a lot of limitations with resources, the management can be really challenging. So preventive measures are the most important things from our perspective, I think. So risk factors, we all know diabetes mellitus is undoubtedly one of the most important risk factors. And in the recent years, with the advent of various chemotherapeutic agents and with the increasing expectancy of life of the patients with underlying malignancy, neutropenia, hematopoietic and solid organ transplantations, and these have emerged as important risk factors. And also the high level of free iron has been proposed as one of the important risk factors for mucormycosis. Briefly about the pathogenesis, it's seen that various factors like hyperglycemia, the high level of serum iron, it's free iron itself, and beta-hydroxy butyrate as part of diabetic ketoacidosis. These all things can promote both the growth and invasion of mucormycosis. It is seen that the high level of glucose would inhibit the various iron chelating and binding agents like ferritin and transferrin, and thus promotes the higher amount of free iron in the tissue at the tissue level. And also similarly, the beta-hydroxy butyrate and other these ketone bodies in the patients with diabetic ketoacidosis. Also, it inhibits chelation of iron and thus favors free iron in the tissue, and then it promotes the growth and extension of mucormycosis. Regarding the epidemiology of diabetes in Nepal, I went through this one important paper that was published in 2020. That was a meta-analysis of various studies. You can see that the prevalence is around 8.5%. It is pretty high, and it is quite comparable to that of the Indian population as well. And regarding the data about mucormycosis, we can see that almost 70% of the cases reported about mucormycosis, they are from India, and probably it is because of the very high incidence of diabetes over there, poorly controlled diabetes over there. That might be one reason why it is so much common in India. And also, it is seen that only half of the patients who are diabetic, they're actually aware of their diabetic status. And even the patients who are under treatment for diabetes, only 1/3 they have the good glycemic control. And it is seen that globally the incidence of diabetes has increased almost fourfold in the last 4 decades. So this can be one reason why this mucormycosis, one which was previously considered as a very rare disease, is emerging again and again in the background of this COVID pandemic. So there is an important interplay between diabetes and COVID-19. It is seen that the patients who are non-diabetics and who acquire COVID, they have a higher odds of developing severe infection and getting hospitalized, almost 3 to 4-fold higher chance of getting sicker and getting admitted in hospital. That is one consideration. And there is another new entity that has come into existence, like the patients with COVID, that they might be developing the new onset diabetes. The patients who were not non-diabetes, they might become diabetic once they acquire COVID because of various mechanisms like impaired insulin production, insulin resistance, production of various counter-regulatory hormones, and destruction of beta cells itself. So that can be one reason why these two pathologies may support one another and in turn increase the incidence risk of mucormycosis. And it is seen that the patients who develop new onset diabetes, they have the worse prognosis than the underlying patients with underlying diabetes if they develop COVID. I was searching the papers, and probably this is one of the largest retrospective studies on COVID-associated mucormycosis that was published a week back in June 4th in Emerging Infectious Diseases journal from India. It was a retrospective study from almost 16 centers, and it was also co-authored by one of the leading world leaders like Arun Lokek, Dr. Bharti over here. You can see that it was from 16 centers. They conducted they did a retrospective study over the duration of 4 months from 2020. And again, they compared the number of mucormycosis a year back, during the same 4 months, and it is obviously we can see that just a moment. We can see that the incidence of mucormycosis has almost doubled in the year 2019, And this white one is the with COVID, and black one is without COVID and with mucormycosis. That definitely proves that the COVID-19 has definitely contributed for the increased number of COVID increase in the number of mucormycosis. And overall prevalence was found to be 0.27% in the patients with COVID. And ICU patients, they had the 7 to 8-fold higher chance of developing mucormycosis incidence around. And the commonest online disease for both COVID and non-COVID mucormycosis this study was definitely diabetes mellitus. And COVID, the patients with only COVID-19 without diabetes, they were responsible for about 1/3 of the patients who developed mucormycosis. And it is interesting to see that almost 80% of the patients in this subgroup as well, they were receiving glucocorticoids. And as discussed before, the rhino-orbital variant is a common variant of mucormycosis in this case series as well. So they have also categorized mucormycosis as early or late onset COVID-associated mucormycosis. Late onset means 8 or more days after diagnosis of COVID. And most of the patients, they had a late presentation with the average time for presentation of COVID was around, mucormycosis was around 18 days from the diagnosis of COVID. Regarding the use of glucocorticoids, they categorize the patients into 3 groups. One category was appropriate. That means the patients got dexamethasone or the equivalent dose of other corticosteroids at a dose of 6 milligrams per day and not more than 10 days. That was what is considered as to be appropriate, and it's based on the recovery trial that I'll be discussing subsequently. And they have categorized. Next category was not indicated. That means the patients who got steroid but who were not hypoxemic, that they labeled it as not indicated. And next category was indicated but inappropriate. That means they got dexamethasone or the steroids, but either at a very high dose, more than 6 milligrams of dexamethasone per day equivalent, or for the longer duration, more than 10 days. And that is how they categorize the use of glucocorticoids. Interestingly, we can see that in the left side, this is the early onset COVID-associated mucormycosis, and the right side is late onset. And only 1/3 of the patients in the late onset mucormycosis, they got appropriate use of corticosteroids. Almost 2/3 had the inappropriate, or they got the corticosteroid when it was not indicated. So this is the evidence about the use of steroids in COVID-19 patients that was published in February 25 from the Recovery Collaborative Group in New England Journal of Medicine, and I think this is the basis for the use of corticosteroid standard of care for now. They enrolled a very large number of patients. Almost 2,000 plus patients got dexamethasone, and almost 4,000 plus patients, and they got the control. And in the study, in the group who got dexamethasone, they used 6 milligrams of dexamethasone daily intravenously orally for the maximum of 10 days. And they found that overall, the patients who got dexamethasone, they had a better outcome, lower mortality. And in the subgroup analysis, they found that the benefit was highest in the patients who were on mechanical ventilation. And the chance of better outcome was highest in this group. And also the benefit was seen in the patients who were not on mechanical ventilation but were receiving the oxygen supplementation. But on the other hand, they found that the patients who were not on respiratory support, and that there was potential the risk of harm in that patient population with increased mortality if they got dexamethasone. So later on, in the same month, on February, there was a meta-analysis published about the use of corticosteroids and different disease severity in the patients with COVID-19. They included 5 studies, including the recovery trial, also the Codex trial, and a few other trials, including the REMAP-CAP and other trials. And they found that the benefit was in favor of corticosteroids in the patients who were on mechanical ventilation, but it was against the use of steroid in the patients who were not requiring oxygenation. So it is important to mention that, and we should know that if the patient is not on oxygen supplementation, those patients should not be put on steroids. So just to summarize what we can do, we can use the steroids very much judiciously. It is life-threatening if we use it properly, in a proper dose, in a proper patients. But if we use rampantly in the excessive dose or in the patients in whom it is not indicated, it can cause harm. And more importantly, the glycemic control is very much important with a target of less than 180 milligrams per TL. I think this is not a very difficult thing to do in a hospital setup. and we need very close glycemic monitoring of blood sugar. We can implement a simple insulin administration protocol in these patients and keep the patients on good glycemic control. A few days back, I was having a meeting with one of the experts from India, from Mumbai, and he was sharing his experience in one of the big meetings, and he was mentioning that he managed more than 1,000 cases of COVID in ICU, and he had 0 patients with mucormycosis, and he thinks that it was because of the good glycemic control he could attain. He could maintain the blood sugar between 140 to 180 milligrams of DL in more than 80% of his patients. So I think glycemic control is one of the main things we can do, and that can help in preventing various complications, including mucormycosis. Definitely, we need very high index of suspicion for early diagnosis, because late diagnosis can definitely worsen the outcome. And as the intensive care physicians or the doctors in ICU, we can facilitate for early appropriate imaging. These patients can be sick, and these patients might need transfer to the MRI or CT scanner. That might be challenging, but still it can definitely change the management. So if considering the risk and benefit, if the risk of if the possibility of mucormycosis is high, we might consider those patients to take to the scanner early on with some added risk. And definitely we can perform to collaborate with different disciplines that might be necessary to get involved in the management of this patient. Definitely early initiation of amputation BP, even before the diagnosis is confirmed, can help and should be considered. And combined medical and surgical management, when indicated, can help to improve the outcome. And also, we are just guessing about the number of cases we have in our countries. We don't have any proper data so far. And there are some news about 8 or 9 patients or 10 patients. Dr. Urmila was mentioning about 8 cases we manage in TUTS. So if we can have a national registry of our mucormycosis in our country itself, then we can have our own data. We can do some research, and we can know better about how the disease is progressing in our country, and what are the added risk factors that we can address. Thank you very much.
Gentle, for your informative presentation. Well, apparently Professor Vasishtha Rizal is back, and he's ready with his presentation. So we'll have him as our last presenter. So please be ready with your slides. Rizal, sir. So are you there?
Vasishtha sir, please unmute.
Vasishtha sir, please unmute your mic.
I think we'll have to ask him to make his presentation a little short, man. Koso.
Yes, sir.
If possible,
I'll talk to him personally.
No, it's already getting 7 o'clock, I believe, now.
Yes, sir.
He just connected in phone that he's preparing, he's getting ready, sir.
Okay.
Yeah.
Hello, are you hearing me?
Yes, sir.
Yes, sir. Yes, sir.
Yeah, okay, thank you.
So please share your slides, sir. So could you enlarge your slides? Slides show.
1 minute पर्ने चाहिँ बस भइसक्यो. Okay. Can I start now?
Sure.
Okay. Today, thank you for again for this organizing committee. I will be very brief because most of the content I think already discussed. So I will be especially focusing on the laboratory aspect. So yes, this mucormycosis is that is already known. This is invasive diseases and fungi, mucorals, and most of the fungi that newly emerging fungi like rhizopus, mucor, rhizomucor, and conumela and Epsidia, they are involved in this mucormycosis, and these are the opportunistic fungi. So you all know that opportunistic fungi, especially rhizopus is involved, rhizomucor is also involved, and the Epsidia and conumela also involved. So they are always they are present everywhere, like soil, dust, environment, and they are not new. And primarily they affect the respiratory tract, especially that is I think already been discussed, nasal cavity, and they germinate it there, and this mycelia embeds inside the different cavity. So these mucorals are fast-growing fungi, have a highly developed mycelium and branched hyphae. Septum is not present generally. Also called this bread mold, and it is called black mycosis. That is misnomer. And this opportunistic mycosis, when we talk about the opportunistic mycosis, there are other fungus also there, candidiasis, this candida, cryptococcus, aspergillosis, and the mucormycosis is there, pneumocystis pneumonia is also there, penicillin also, penicillinosis also there. So there are many other, and in addition to that there are Fusarium, Peliciomyces, Biopolaris, and there are many. So we should be aware that this fungi has been recently, this taxonomy has been modified. So this current species, the previously which is known as Epsidia corynobifida, now it is Lithanemia corynobifida. Similarly, Epsidia orenta, now it is called Lithanemia orenta. Similarly, Epsidia ramosa, that is Lithanemia. So there is a change. So you should, when you go and read the textbook, also the journal, it should be, you should also find those things. So the clinical manifestation I don't have to tell, because most of the thing has been already discussed. So they progress rapidly and can cause lethal fungal infection in human, as we all know that. So usually the nose is the entry point, and paranasal sinuses where they grow, and from there it will go to the brain and also to the the eye. Can cause rhino-orbital, orbital, cerebral, pulmonary, gastrointestinal, and the blood, this disseminated infections, even urinary tract infections. So diabetes already discussed is about diabetes mellitus is independent risk factor, and the rhino-orbital cerebral mucormycosis. The main duration for COVID infection and development of mucormycosis was 15 days and plus minus 9 days. So I think 15 to 10 to 30 days. So the hematological malignancy was associated with disseminated mucormycosis, solid organ transplantation with pulmonary, gastrointestinal, and disseminated mucormycosis. So when we talk about these mucors, these are filamentous, and this is the rhizopus is the most common mucor, which can cause the mucormycosis about 50% of the cases, and this can be cultured in the simple fungal culture media, which is called Saprodextrose agar, and clonies can be seen within 3 days. Under microscope you can see the unsepted hyphae, there is a rhizopus, there is a sporangium, so that microbiologists can detect that. So this is on the LCB mount, which is done in the laboratory, leptophenol cotton blue mount from the growth rebuild accepted hyphae, and short sporangiophores with a terminal spherical sporangia filled with brownish sporangiospore. That's how you will see in the laboratory. This is filamentous fungi. This is, you see the sporangium here, and this is, see the hyphae, and this is also you can see the rhizopus as well. So this is sometimes there should be a differential diagnosis, like aspergillus also opportunistic fungi. So we should be able to differentiate it from the aspergillus mycosis. So another is that penicillinum. Penicillin is also rampantly everywhere. It is available, and it can contaminate, there and cause the disease in the opportunistic infections in the COVID patient, as well as other patient with a transplant and other patient. So sorry. So now I will talk about the laboratory diagnosis. So laboratory diagnosis sample collection based on this site, like nasal swab, respiratory secretion, sputum, tissue biopsy, bronchoalveolar lavage. If you are getting from the lesion from the margin, you have to take the biopsy, and bronchoalveolar lavage, blood, even disseminated infection, blood samples should be taken also. So the most important thing that clinicians should know is the direct microscopy, the KOS mount, which is available in the any laboratories and very easy. Clinicians just can go and they can also see themselves. So that this is very important, can be applied to all materials to the laboratory. And if there is additional dyed fluorescence dyed like calcofluor white with the KOS, it will be seen more clearly. And this is the one nowadays, until today, this is the gold standard for the diagnosis of fungi. This is inexpensive and very useful, and the presumptive diagnosis is can be done. So surgical, if you are doing from the surgical sample, should be taken from the margin, from the lesions, so that you can see the invasion of the fungus to the tissue. And this direct microscopy, so you can see this like a rhizopus in the direct microscopy like this. You can see the hyphae, you can see the sporangium, you can see the sporangium, hyphae, and so it should be correlated with the clinical diagnosis. So this fungus culture medium is as this cephalosporin agar. Most of the mucorals can grow in 37 degrees Celsius in 24 to 48 hours. But there may be false positive culture. So we must correlate it from the clinical sign and symptom and other hematological parameters, that is X-ray and the CT scan, MRI, it should be correlated. Otherwise, false positive culture may be there. Identification is based on the colonial morphology, microscopic characteristics, and growth temperature. So the histopathology, as I said before, this definitive diagnosis is based on the demonstration of fungal hyphae in typical mucor biopsy affected tissue. If there is invasion to the tissue, that is the diagnosis. Otherwise, even the PCR and the culture may be false. So it can demonstrate tissue and blood vessels invasion as well. So this is the histopathology. Till date, histopathology is the important and the gold standard. So to make it better, this glucomethylamine silver stain and periodic acid pass stain, which is available in the laboratory, can be done. And so close collaboration between the laboratory and the clinician is necessary. And the molecular methods, molecular techniques that already have grown in culture, you can do the PCR or other molecular technique from the culture or from the sample, but there is a chances it is not standardized yet, so there is a chances of getting false positivity. So molecular method also should be correlated with the KOS mount and the histopathology, also to the clinical and the CT scan and this X-ray. So PCR-based techniques such as nested PCR, real-time PCR, nested PCR directly from the tissue, it can be done. So, now it is said that this for invasive disseminated infections, especially in the ICU, if we can do the blood PCR from the blood itself, it will be very reliable. Otherwise, molecular test should also be correlated with the histopathology and the clinical, and also to the MRI and the other CT scan and the radiology, whatever is available. So it should be evaluated with the direct smear and the histopathological examination. And the serology, till date there is not standardized. There are serological methods. Anytime it may come to the market, but it is not standardized yet. And the summary is that for diagnosis of mucormycosis remains challenging. Histopathology, direct examination, and culture remain essential. They are the three tests and should be correlated with the clinical the findings, and also the other radiological findings, and so on. The molecular methods are improving. I hope that it will come after 2-3 years or some near future it will come. So methods on detection of mucorous DNA in blood have shown. So I have already told that in blood, in disseminated mucormycosis, it is reliable. So screening test, so promethazine could be used as a screening test in a high risk person, but have not validated in clinical studies. So these molecular methods still need some improvement. So finally, this mucormycosis is emerging opportunistic infection in immunocompromised patient, as already previous speaker told, that is severe neutropenia is the most problem causing this mucormycosis. Another one is patient with renal dialysis and getting the antichelating agent. So for this diagnosis, what I want to tell is that there is a irrational use of antibiotics, which will kill all the these normal flora, should be stopped, and this randomly using the steroids in the community as well as in the hospital should be there should be some limitation. Prolonged steroid use is one of the important factor for getting this flowering of this mucormycosis. So physician, ENT surgeon, ophthalmologist, microbiologist, pathologist, radiologist, and all the related experts should work together to contain this mucormycosis. With this, thank you very much. There was some problem for this electricity. I am sorry for that. Thank you very much for giving me this opportunity. If there is some question, I may be able to answer. Thank you very much.
For ending this brainstorming webinar with your microbiological perspective in mucormycosis. So now we have come to the end of this webinar. And our final session will be the discussion and question answer session. And I would like to request Dr. Malita to take over this session.
Thank you, Dr. Chandni. So there are a few questions from the audience view. So I like to put forward first with Dr. Urmila. So they have a few questions for Dr. Urmila. The question is like this: did you confirm your clinical diagnosis with biopsy before surgery among your video patients?
So yeah, thank you for the question. So we there was a very strong clinical clinical findings that we saw on the patient. So that's why we went ahead with the surgery, and also the amphotericin. Sorry, we started with the amphotericin B infusion, and then went ahead with the surgery before we did the biopsy. And because we didn't have much time to wait for the histopathological report to come, so based on the clinical finding as well as the radiological finding, where there were areas of areas which did not take gadolinium enhancement, based on that we went ahead with the surgery. But we did send the specimen for histopathology, KOH mount, and culture, and it did show mucor on KOH, aseptic hyphae on KOH mount. It drew a rhizopus on the culture, and histopathologically it was also confirmed that it was mucor.
Thank you. And the next question for Dr. Urmila again. So is it necessary to prescribe prophylactic antifungal before performing punch biopsy of nasal mucosa?
Yes, as I've already emphasized again earlier, it is the clinical high index of substitution based on which we start the medications, because it does have the mucormycosis does have a very typical features that we've discussed earlier. So and also because the investigative reports may take time to come back. Since this condition is rapidly progressive, we have to start the medications as early as possible on empirical basis.
Thank you, ma'am. The next last question is again for you. So is the black fungus found mostly on Delta variant types of COVID?
We do not exactly know why it is occurring so much at this particular second wave, but probably it has to do with the Delta virus, because coronavirus, the other variants were there previously as well, but this is a new strain which is seen more. Yeah, and we as this where there are maximum number of mucormycosis, so probably it's to do with the variant, but it's I think the studies still have to be done to prove that it is correlated with the variant.
Thank you, ma'am. Now,
next question.
Next question is for Dr. Rohit Saizu. Is intraorbital liposomal amphotericin B given for orbital extension?
Thank you, Malita. I just want to give supplement to the previous question. That this new mutant variant of COVID virus has proven that it has capability to break the mucosal immunity of nasal and oral mucosa, as well as the upper part of the respiratory and gastrointestinal tract. That's why this mucormycosis in this time became so fulminant. It has published that the new variant has the potency to break the mucosal immunity of the system. That's why this became so fulminant. Okay, I'll come to my question now. Can you repeat once again the question?
Yes, sir. The question was, is the intraorbital liposomal amphotericin B given for orbital extension?
Okay. So intraorbital liposomal is given to the orbital involvement if it is localized. If it is not a diffuse one, if it is localized in the posterior one part, mostly the middle portion of the orbit is more involved, or the apical portion one is involved, like the pterygopalatine fossa is the portal portion from where the infection can spread directly to the posterior part of the orbit, not involving the anterior and middle part of the orbit. In those cases, the intraorbital amputation, the retrovalvular injection have the role, but not in the diffused one where the whole orbit is involved. The role of the amputation is very difficult, and it is given in the subsequently in 7 days or in alternate day in 3.5 milligram per ml without giving any lidocaine or any combination with the anesthetic, local anesthetic, because there is no role of anesthetic, as there is a mostly individualized tissue and patient doesn't feel any pain. So directly you can introduce to the orbital cavity. Yes.
The next question is again for you. Does all cases of panophthalmitis warrant COVID testing like PCR and antibody test if PCR is negative?
Yeah, we do all the cases of surgery with the PCR confirmation, as my hospital is not the COVID hospital yet. That's why we do not have the facility to entertain the COVID patients. So all the cases, even the procedure like intravitreal injection, which is very short and quick, also we confirm the PCR negativity and then proceed. So that's why all the surgical cases, including the panophthalmic cases for the enucleation, should go PCR first.
Again, the next question is for you. When we should decide for enucleation, is there any scope of preserving eyeball?
In rhino-orbital mucormycosis, there is not much involvement of the eyeball, so there is no question of the enucleation, question of the exenteration, because the orbital tissue is involved basically, not the eyeball. So mostly we do the exenteration if the eyeball, including the orbital tissue, has involved, because the route of the spreading the fungal infection through the ethmoid sinus and sometimes from the maxillary sinus. That's why we can see the thickening of the inferior rectus instead of the medial rectus in those cases where the infiltration is spread from the maxillary antrum. And mostly the ethmoid ear cells are the site from where the through the laminar papilla, a thin bone, the fungal infection spread to the orbit. That's why exenteration is the choice of the surgery to evacuate all the devitalized and the affected tissue by fungus is removed. That is exenteration, not the enucleation.
Thank you, sir. My next question for Dr. Rizal.
Yeah.
So there is a question for you. How should we send the sample to lab for culture, molecular study, and histopathological study?
Yeah, the nothing special is the sterile from the from the swabs would be sterile, and this should be sent as early as possible. And this in the laboratory, there's direct microscopy can be done within half an hour, and the histopathology may take a few hours, and this, so there is a, if there is a surgical specimen, it should be the margin of the surgery should be included as well to see the dissemination of the this fungus, mucormycosis, fungus, mucorals.
Malika, can you name the our colleague who put the question so we can identify who is asking?
So the recent one that the Dr. Rizal has just answered was from Dr. Diwa Lamithani. And the questions that I have kept for you with the panophthalmitis and for enucleation was from Dr. Kunjan Acharya. He is a ENT specialist. And for the Dr. Urmila, the first questions for the diagnosis of a biopsy was from Dr. Ben Limbu, who was the orbit and oculoplastic surgeon from Silganga. And the next is from the Dr. Saurabh Pia from Vietnagar. So now, may I request Dr. Chandni to proceed? Dr. Chandni?
So I'll be asking few questions which we received in YouTube. One of them is from Dr. Prachanda Gautam. He is also an ophthalmologist. His question is there any role of voriconazole? So I think anyone can answer that.
Shall I answer? So voriconazole, in fact, is considered a risk factor. Those on voriconazole, they are susceptible for developing mucormycosis. So voriconazole should not be given, even when we're suspecting mucormycosis. So mucormycosis has been seen in patients who've been on voriconazole for other medical conditions.
Thank you, ma'am. So another question is also from Dr. Prachanda. He has asked, can we inject or flush the paranasal sinuses with amphotericin B? Can we inject or flush the paranasal sinuses?
So one of the protocols that we can follow post-operatively is flushing the nasal cavity with amphotericin B deoxycholate, which is it's relatively easily available than liposomal, and also very, very cheaper as compared to liposomal amphotericin B. So that also has been suggested to reduce the inflammatory changes that are surrounding the fungal sites of fungal infection. So yes.
Next question is again from Dr. Prachanda. He's asked, can we inject amphotericin B over the involved extraocular muscles, or do we always have to give it retrobulbar? So this is for Dr. Sanju.
Okay, thank you for question. We do not give intramuscularly in any extraocular muscle inside the orbit. Our intention is to give the part of the orbit, whether it is the lateral, superior lateral, inferior lateral, superior medially, inferior medially. In that portion, the diffusion these drugs will act in the surrounding area, and mostly we give in intraconally. What the procedure I have described, that exactly the same way how we give the retrobulbar injection. We accumulate the amphotericin B intraconally, especially for the apical portion of the orbit is involved. It depends on the location, and accordingly you choose the site. If the superior medial orbit is involved, where the ethmoidal and frontal sinus is very adjacent, you have to give accordingly superior medial side, but not inside any structure like muscle or nerve inside the orbit is not given.
Now the fourth question is from Dr. Bikash Kamal. I don't know where he's from, but he's asked, till what time or duration after recovery from COVID mucormycosis is suspected? Till what time or duration after the recovery from COVID should we suspect mucormycosis?
It is said that till 8 weeks after recovery from the COVID, we should be watchful for them, because that is a vulnerable period and we should be very carefully watch, and the diabetic status and all the general status should be in the normal. So 8 weeks it is said, and sometimes more than that also it will be extended.
Thank you, sir. Now I'll hand over to Dr. Malita. Malita, please unmute your mic.
I think we should open the floor if there is any discussions amongst our speakers and panelists.
Can I have a question?
Can you hear me?
Sir, yes.
Saju,
yeah.
Rohit, I think I must congratulate you. Your presentation was too comprehensive, I think most of the ophthalmologists won't have any knowledge of mucormycosis to that extent. And I think we all ophthalmologists must have learned a lot on mucormycosis and the eye. Congratulations. Thank you very much. One or two questions or comments. Like you said, if there is PCR positive, we do not do the surgery, at your center. You refer it somewhere else, And we don't have many orbital surgeons, who will be ready to perform surgery on a severe case of orbital, let's say, mucormycosis. So I was wondering, what do you do to your patients who are PCR positive and need surgery? Number one. Number two, you said about this mucormycosis, you get it post-COVID in 2 to 4 or 8 weeks, you said. But I think you get mucormycosis even in COVID patients as well as in post-COVID patients also. That's what I think I heard somewhere and I read somewhere. In other words, you can get mucormycosis not necessarily after a certain period, 2 to 4 weeks or 6 weeks, they say, but you can get it in patients with COVID also. That's all. I think I was asking you, maybe you have more experience because I don't remember seeing COVID patient. Maybe I saw one aspergillosis involving the eye and the orbit, almost like this mucor, but not to that extent, Do you want to reply to one or two queries I just made?
Sure, sir. Sure. Thank you for the question, sir. Regarding the first question, I am very much grateful to be part of the mucormycosis team to manage of those patients, whether it is COVID positive or COVID negative, it doesn't matter for me. I'm saying that in my hospital, this is the COVID negative hospital. We don't have any facility to entertain any COVID positive patients. We don't have theater for the COVID, and same way other facility. If Dr. Urmila invite me to do exenteration in her setup, I'm very happy to work with her.
Good.
So I'm open. If anybody invite me, I'm very happy to do my skill for my patients. And regarding the second question, sir, the most vulnerable period is post-COVID patients.
Right.
Most of the mucormycosis has seen. So they come back from the hospital and taking recovery at the home with a very weak immunity, and where most of the speaker has mentioned the risk factor for them, if they are not well controlled, diabetic, or they are not well, still feeling good, and other risk factors are still there, those 8 weeks should be very watchful. It is recommended, but it can happen during COVID time also, beyond 8 weeks also. So mostly these 2 months is very crucial time to be watched by the team.
Anyway, thank you very much. Can I ask if to Dr. Basanta, if he's still around? Is Basanta there?
Yes, Dr. Molla, I'm here.
Yeah, Dr. Basanta, one or two. Number one, you very much was highlighting black fungus, The other day I heard somebody talking about white fungus also. Why do you think the fungus is black in color, To my knowledge, I thought it's some kind of pigments, the black pigment. But as a matter of fact, what I read is it is due to ischemia, infarction, and necrosis. And the necrosis is SR. The color is black, That's why it's called black fungus. That's what I heard, I don't know what you have to say there. Number two, about rhinocerebral. We always talk about rhino-orbital cerebral. Is it possible to have the cerebral affection, just rhinocerebral? In other words, like you pointed out, the cribriform plate there, from the nose and sinus can go straight to the brain, at least the frontal lobe, right over the cribriform plate. So have you seen a case where the orbit not involved? Normally the root is rhino-orbital and cerebral, but it can go from rhino to cerebral straight away also, isn't it? And number three, my question, number two thing is we are lucky that most of the time we are seeing only one eye involved. The other eye sometimes get involved, not to that extent. Is it that the disease has progressed from one eye to another, or it goes back through the cerebral, the cavernous sinus, and then from one cavernous eye to the other, and the involvement of the other eye, which is very rare. Luckily, we do not see so often the bilateral orbital involvement, Just a few queries,
Okay.
Is that all? That's all I have to say now.
So I'm sorry, I cannot get my video on, so you just have to listen to me.
Audio is good enough.
Yeah. About the first question, the fungus itself is black, so it has got a black pigment. So that's why it looks black, but it also causes necrosis. So maybe there's an add-on necrosis. But the fungus itself is black. So that's why it's called black fungus. And about the second question, of course, it was about can the fungus go straight from the brain, right?
Rhinocerebral.
Yeah.
Not involved in the orbit.
Absolutely. Actually, there's a lot of nomenclature problem here. There are some papers where they just call rhinocerebral, and there are some papers where the cerebrum is omitted. So as you have said, through the cribriform plate or through the cavernous sinus, because the dura has got a continuous connection with the ethmoid sinus in the cavernous sinus area, so that can easily, the inflammation can easily pass through to the cavernous sinus and to the brain. So orbit can be omitted. And
I see. Yeah.
Most of the time, I think it's omitted.
I see. That's true.
And about the bilateral involvement of the eye, like one is, if you look at the anatomy of the cavernous sinus,
right,
there is a connection between the right and left cavernous sinus, anteriorly and posteriorly. So if you have a cavernous sinus syndrome, a very bad infection of cavernous sinus, which will also have orbital effect, then that can go into the other also. So, and also there is a possibility of the infection spreading through the optic nerve itself, the other nerve, through the chiasma,
Yeah. Okay.
Yesterday, just 2 days ago, I mentioned that I operated on a patient who had a very big swollen, bilateral optic nerve swollen, and the left optic nerve was extremely swollen, and I actually longitudinally cut the optic nerve to decompress the optic nerve itself. I don't do that. That was the first time that I did it. And that technique I learned from the leprosy people.
Right, I see.
People, whenever you have got a thickened nerve, and then the epineuron is a constricting factor. It is working as a constricting factor for the nerve itself. So if you just cut the nerve longitudinally, then it will be decompressed, and then you'll be relieved of the symptoms. That's what they do, in leprosy. And I did the same in this patient, and surprisingly, the next day, her vision also improved, although it was NPL.
In that context,
infection can cross through a venous channel, or it can cross through the anatomical connection of the optic nerve itself.
Okay. So in that context, in regard to this patient, you mentioned papillitis, and I thought maybe it is papilledema. Both eyes, optic nerves were involved, and there must have been a component of raised intracranial pressure there to account for the papilledema, rather than papillitis, I thought. Anyway, whether it is inflammation of optic nerve only, if it is bilateral, it's got to be papilledema, and it's always due to raised intracranial pressure. I'm talking about in this patient. You mentioned papillitis also, didn't you? Or probably it's papillitis and it's unilateral.
No. This patient had bilateral optic disc edema. Left side was more than right, and she had a orbital apex in left side.
I see.
And but this is optic neuritis, which is crossing over to the other side.
There was no raised intracranial pressure. No.
Oh, there is no intracranial pressure. No, it was not due to.
Okay, good. Got it. Thank you.
Thank you.
Rohit. Dr. Rohit there?
Yeah, I'm here, sir. Yes, sir, I'm here.
Dr. Rohit, if the question answer finished, can you make few statements? Or you still have no time?
No, I have time, sir. I have time. So, statement regarding what, sir?
About COVID only, about the mucor. Some of the points, I thought I better speak out now. For example, about prevention of mucormycosis is one of the reasons. Somebody pointed out the mask. But the tendency for people to use the same mask for so many days. It is said that you got to change the mask, the surgical mask, after 3 or 4, 5, 6 hours, which is less possible in our population. They are expensive, but it is important that you change the mask. If it is cotton mask, you can wash it, because otherwise the moistened mask will try to help the mucor to proliferate, without your knowledge. since they are resident in your mucosa normally, also the spores are present, So whenever you use a mask, this is for people, to know how to. You can't use the same mask, surgical mask, for so many days. People do that in our country, isn't it? So
yes.
that has to be explained to the patient. And also, and another thing you people have pointed about treating this patient at the earliest with amphotericin B liposomal, and there it is pointed out you got to start immediately, and you have to work out the calculated dose. 5 to 10 milligram per kilogram body is the weight, is the dose, but they reckon it's better to start not 5 but 10 milligram per kilogram of body weight amphotericin straight away, within 4 or 5 days or something of the beginning of the disease, So in other words, calculated dose. You could calculate and start 10 milligram rather than sometimes we start with small dose and then tend to increase it over a period of few days has to be discouraged when it comes to managing or treating mucormycosis. You understand? That's what calculated dose.
Sir, regarding the dose of the amphotericin B, it is standardized. It is standardized like if there is a rhino-orbital mucormycosis, the standard dose is 5 milligram per kg. 60 kilos person have to take 300 milligram. 10 milligram per kg is for the brain involvement, sir. It is.
I see that one.
Only for the CNS involvement, patient will take the 10 milligrams.
No, good.
Because it is very toxic to the kidney.
5 to 10.
Yeah, very careful.
Okay, maybe cerebral involvement, extensive involvement where you start 10, another 5, 10 is the usual dose they recognize.
And the duration of the amphotericin B also said like it is better to have for 4 to 8 weeks, but at least
4 to 8 weeks.
8 weeks. But at least for 2 weeks, as the medicine is very expensive.
That's right.
Availability also in question now, the production. There's a big scarcity in the India and so Nepal also. And at least 2 weeks we have to give amphotericin, and then pasaconazole can be continued. That pasaconazole should not be the first line treatment, but it can supplement with the amphotericin B like that said.
But then the amphotericin B is pretty expensive, like you said. It's very expensive, but it is at the same time good. It is fungicidal, as opposed to posaconazole, which is fungistatic, But if you do not have amphotericin B easily available, people have used posaconazole, intravenous also. Something better than nothing rather than, because in India they have found the mortality rate is 50 to 90 to 100%.
Yes.
If you talk about these people in the rural area who don't get this kind of treatment, immediate amphotericin, immediate complete debridement, all these things are not available there. So I heard some people say in the rural area, maybe the same here, where the service is not there, you do not get antifungal, you do not get debridement on time, the mortality is 100%. Also 90 to 100, let's say 100%. So that's the. Anyway, thank you very much. Wonderful. All the speakers have done full justice, the topic you have given to them. I was amazed, I learned quite a lot, even in ophthalmology also. Thank you very much, Rohit, for including me in this webinar, I better stop and let others speak now.
Yes.
Rohit.
It is great pleasure to have you, sir. You are always encouraging, and in the discussion part, you are always heroes.
No.
Yeah. I would like to ask Dr. Bimal Sinha, so all these commensal, opportunistic commensal, including mucor, candida, aspergillus, why the now issue about only the mucor? Why not the aspergillus and the candida's cases are less, or it is not coming up in the news? Do you have any idea, Dr. Bimal?
The thing is, I think in the recent days, the normal patients have stopped going to the hospital itself. And there's a lot of overload of these serious COVID patients as well as the mucor patients. And I think the lot of etiology that we have presented here the most common cause for mucormycosis is the uncontrolled diabetes and overuse of steroids and all that. Whereas this non-invasive type of aspergillus, because if you see the classification, pathological classification and clinical presentation, there are three categories divided. As one is invasive fungal sinusitis, non-invasive, and chronic granulomatous. In these aspergillus group, they come under non-invasive type of sinusitis, and they usually affect the immunocompetent persons. That's not common in immunocompromised persons. Immunocompromised persons get affected by mucormycosis. So even the diabetes and all that, that's not very common in aspergillosis. So maybe this opportunistic infection of mucormycosis is more common during this immunocompromised status period rather than the other kind of non-invasive fungal sinusitis.
Thank you very much, Dr. Sir. I have a question to Dr. Gentle. Dr. Gentle, you are there?
Yeah. Yes.
Yeah. Thank you. Did you have chance to treat the patient with post-COVID mucormycosis in teaching hospital? One. Another, how did you find the response of remdesivir in the management of the COVID patient? Is there any positive or any adding factor in the management of the COVID patient in your practice?
So regarding our first question, sir, as Dr. Urmila also mentioned about the number of cases we manage in TUTS, she has mentioned about 8 cases. And among those 8 cases, 2 of them were managed in ICU itself. One of them is still in our ICU, and he probably has an extensive involvement. He has rhino-orbitocerebral involvement, and possibly he'll be undergoing surgery, like to the blade presentation. So we're dealing with the patients in TUTS, and among those 2 were managed in ICU, 1 in ICU itself at present. And regarding the role of remdesivir, there was one famous Act 1 trial that was published in NEPAL almost a year back. And what they showed was that the use of remdesivir, it doesn't decrease the mortality, but it can decrease the duration of illness of the patients, especially if it is used earlier on. That means within 10 days of onset of symptoms of the patient. So as for the international guidelines as well, and as for the Nepal Medical College and Nepal Medical Council guidelines they have given up, what they recommend is to give remdesivir only if the patient is within those within the initial phase, that is in the phase of the viral replication. Within 10 days, if the patient comes, and if the patient doesn't have other side contraindications, like if the patient has raised liver enzymes more than 5 times of upper limit of normal, or if the creatinine clearance is less than 30, we don't give remdesivir to those patients. But if it is not like that and the patient has come early on, then we might give remdesivir if it is available. But it doesn't have the mortality benefit.
Thank you very much, Dr. Gentle. Dr. Urmila, I have a question to you. Did you have to combinedly manage your post-COVID mucormycosis cases with ophthalmology? If so, how many cases you did together, like for the debridement and exenteration or whatever, with the ophthalmology colleague there? And another question is, you must have using amphotericin B for your patients, as this is the highest center where the number of so many mucormycosis cases are treating in the country. What is the availability of amphotericin B and how it is costly? This is for the general knowledge, general information to all the colleagues.
Thank you so much for your question, sir. So firstly, we, as I mentioned in our presentation, that we have a mucor group which consists of faculties from different specialities, and to manage the cases, we especially those who had orbital involvement. My ophthalmology colleague is also involved. So when we took the 2 cases for surgery, my ophthalmology colleague was also there. And he did assess whether there was any need for ophthalmologic procedure intraoperatively. So, but until now, we haven't had any patients who've undergone exenteration yet. But we do discuss our cases with each other before we go for surgery. But till date, we haven't had any cases undergone exenteration. The first case that we operated, it was the first case, so I mean, there was some lack of experience for us. I would have to admit that. And we did an extensive debridement intranasally. But for the eye, I think we, after discussing with my ophthalmology colleague, we just decided that he would be treated with injectable amphotericin B. He had received retrobulbar injection as well of amphotericin B. But in the due course of time, post the first surgery, his eye symptoms in fact improved, not to a totally 100% extent, but it was improving. But at I think around 10 days post the first surgery, his eye symptom deteriorated. So he underwent the second debridement of the nasal cavity, the nasal surgical cavity, along with middle and the inferior wall orbital decompression. So my colleague was there, my ophthalmology colleague was there during the surgery, and he had a look at the orbital tissues, which he thought was okay. So we just ended the surgery without exenterating the orbit. And even after the second surgery, his eye symptoms have improved. So as of now, no exenteration till date.
Mm-hmm.
Coming to your second question, so yes, amphotericin B is very difficult to get here in Nepal. Initially, the patients had to get it from their own, with their own effort from India and anywhere they could get hold of. But now the government has been supplying the liposomal amphotericin B. So anybody who needs amphotericin B, they have to take an official letter from the hospital to the health ministry. It's the EDCD. It's the Epidemiology and Disease Control Division which supplies the amphotericin B to the patients who need them. And I just knew yesterday that it's given free of cost as of now, but they have a limited stock, and they provide it only for 2 days. So every second day, the patient party have to go to the office to obtain the liposomal amphotericin B for 2 days only.
So that is a great job done by.
Rohit, is Dr. Shrestha there?
Yeah, Dr. Gentle is there, sir.
Gentle, sir. Can I ask Gentle, Dr. Malaya? You know, regarding remdesivir, just mention, that you don't use it, if at all you could use it within 10 days. But recently, only the other day, the government of India has come out with this final kind of protocol, how much is going to be effective, I don't know, wherein they have mentioned, number one, tocilizumab in severe cases, and routinely steroid, dexamethasone or methylprednisolone, and low molecular weight heparin in anticoagulation. And this drug tocilizumab is very expensive, also not easily available. I was surprised, I read it. It was in just day before yesterday, I believe yesterday, government of India has come out with, and no need of your supplements, vitamins and all that, So main drugs in the treatment of COVID, I'm talking about, not mucor, are steroids, number one. Of course, there are signs of inflammation like storms and all that. You also pointed that out. And number two is, of course, routine prophylactic low molecular weight heparin, prophylactic dose, not the therapeutic dose, unless sign of thrombosis and others are there, better than me, So this is very recent. And whether you are aware of this new Indian protocol from the government of India or Ministry of Health or whatever, what do you say to that? If you are not aware of it, that's a different thing. But then I was wondering, because I read it only the other day only, very, very, very new. has come out in the papers also, I believe. Okay, please. What your thoughts? What your thoughts are?
Thank you for the question, sir. And I think all the recommendations that the Indian government has come up is very much valid and it's more rational. As compared to this recommendation, the older recommendations were a little bit biased. Like previously they recommended for hydroxychloroquine, drugs, and that didn't actually have much evidence, probably because of this emergence of mucormycosis and all these things. The recent guidelines, as sir has mentioned, it is very much stringent. They don't, and then they have told to use steroids, preferably dexamethasone, as per the recovery trial, 60 milligrams per day, and not to go with the higher dose at all. That is one of the recommendations. Definitely, as you said, steroids are the cornerstone of management. We use in almost all the patients requiring oxygen supplementation. And next thing is about anticoagulation. As sir mentioned, we go with prophylactic dose anticoagulation, and we don't dose the anticoagulation based on D-dimers. Many people are practicing that. Like if the D-dimer is high, they assume that the patient might have pulmonary embolism. Unless we have the documented evidence of pulmonary embolism, we don't go with higher dose. There are recommendations from the American Society of Hematology as well. And there is one recent trial that has published that the anticoagulation should not be based on D-dimers. And unless proven DVT or pulmonary embolism, just to go with a prophylactic dose. Going with a higher dose might increase the risk of bleeding. And next is about the tocilizumab. That is a new drug. That is an interleukin-6 antagonist.
Inhibitor.
Yeah, it is one. And there are a couple of trials. The two most prominent are from the REMAP-CAP, and next is one from the recovery group again. And they just recently, in this month of May 1st, they published this recovery trial. And in the previous one, they come up with the REMAP-CAP trial. And there is also one negative trial. And we also have one recent meta-analysis. Based on that, the recommendation is to use interleukin-6 antagonist tocilizumab, especially in the patients early on, those they have who are at a very high inflammatory state, those that they haven't progressed with multi-organ dysfunction. Like in the REMAP-CAP, they enroll the patients within 24 hours of organ support. Like the patient has requiring the respiratory support or cardiovascular support within 24 hours, or in the recovery trial, in the patients who were hypoxemic saturation less than 92% and with the CRP level more than 75, those patients were benefited. So the patient selection is very much important, sir. And one of the major side effects of this tocilizumab is the patient can land up with sepsis and ongoing bacterial sepsis. So we have started using tocilizumab in Nepal as well. Till a month back or something like that, it was not available, and it was people used to bring with through the black market, and some of them have paid almost up to 6 lakhs Nepalese rupees for the single dose of grams. But now it has come through the government, and it is available at the price of 60,000 rupees for 400 milligrams. The dose we use is 8 milligrams per kg, and they have a prerequisite, like we have to fill up all those forms. There should be evidence that the doctor has recommended. There should be evidence that the patient actually needs the drug, and we have used in a couple of patients, and especially in the patients in whom the patient selection has been good, the outcome has been reasonably good. So the patient selection is very important while using this drug.
Okay, thank you very much.
Thank you, sir.
Thank you, everyone, for this wonderful webinar. Thank you all our esteemed speakers, our panelists, all our participants for making this webinar a very successful one. We are sorry we will not be able to include all your questions because we are really running out of time right now. So now we would like to conclude our webinar with vote of thanks from Dr. Rustom Joshi, who is the General Secretary of Nepal Ophthalmic Society.
Thank you, Dr. Sandhani. Respected chair, panelists, speaker, moderators, and participants. Namaste and good evening. I would like to thank Chair Professor O.K. Malla sir, whose presence itself enlightens the discussion and the question answer session. And he has been an inspiring source for us all. And I'd like to thank Rohit Saiju sir also, through whose initiative we could do this webinar. I would also like to thank panelist Professor Bimal Sinha sir. It was nice to see you after a long time. When I was a resident, we had surgeries with you and Professor P.C. Karmacharya sir on every Thursday. After a long gap, we could see you and hear your knowledge and share it. And I'd also like to thank the speakers, Dr. Rizal, who highlighted about the microbiology of mucormycosis and its laboratory diagnosis. Dr. Urmila Gurung with excellent videos, and Rohit Sanju sir with emphasis on the radiographic diagnosis, and Professor Panta with a word of caution on other opportunistic infections other than mucormycosis that might be on the way coming up, and Dr. Gentle Sundar on his perspective about the critical care, and with a emphasis on the need for a national registry of the COVID patients and the COVID patients we have on the mucormycosis as well, so that we can publicize it and use it to our effect. And I'd also like to thank the moderators, Dr. Malita and Dr. Chandani, for excellently smoothly running the webinar. And I would like to thank Sun Pharmaceuticals, who has supported us. This is the third time they have supported us, and I'll not take much of the time. Dinner is ready at your respective kitchen. It's already late, and I hope that we will have a physical meeting followed by a cocktail dinner very soon. Stay safe. Thank you and good night. Namaste.
Namaste. Thank you.
Thank you.
Thank you. Can we all come for a photo sessions? Everybody just open the video, and in screen we can see all of us together. कसरी गर्ने हो यो एकैचोटि आउने बनाउनु पाए हुन्थ्यो आउँदैन है
I would like to add few things, like it has been a very successful webinar. We had more than 350 participants, 300 plus participants on this Zoom meeting, and 50 plus participants in the YouTube channel. And there were, it was a very interactive session as well, with more than 70 questions in this Zoom webinar, and more than 10 questions in the YouTube channel. It has been a very successful webinar. Thank you very much.
Dr. Purushottam, is it recorded?
Yes, it is recorded.
Okay, okay, thank you very much.
Gallery view try गर्न सकिन्छ होला सर. We can try gallery view.
All participants.
त्यो गर्दा सबैजना आउँछ सर. सबैजनाको पिक्चर. Gallery view. टपमा राइटमा. एउटा स्पिकर भ्यू एउटा ग्यालरी भ्यू हुन्छ सर.
डाक्टर पन्त देखिएन.
डाक्टर पन्त गइसक्नुभयो सर.
All participants भनेर.
विमल सिन्हा सर देखिएन.
हुनुहुन्छ. ल ओके नि.
यस सर देख्नु.
ल हस्.
Thank you.
Thank you very much.
Thank you, Chandni. Thank you.
Thank you.
Last time I met you in Japa. Very good. Welcome.
Okay, sir.
Nice knowing you, Gentle. Beautiful.
Meeting using your remote control. Please enter the meeting ID followed by # or # sign.